pagi, Bapak Ibu. Apakah suara kami dari kantor Menteri Kesehatan terdengar?
Selamat pagi Bapak, terdengar Bapak.
Terdengar dengan jelas ya. Untuk tampilan gambar bagaimana Bapak Ibu? Izin. Untuk
Bapak
gambar
ya?
terlihat jelas ya untuk gambar.
Sudah jelas, Pak. Jelas
Sudah
sekali.
jelas ya?
Baik, baik. Terima kasih.
Terima kasih
Makasih,
banyak, Pak.
Pak.
Excellencies, distinguished guests, participants, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh, salam sejahtera, Om Swastiastu, Namo Buddhaya, salam kebajikan, may God peace be upon you. Good morning, ladies and gentlemen, and we are delighted to welcome you for the opening ceremony of the second International Lighthouse Student Conference 2022 Stikes Mitra Keluarga Indonesia. We are welcoming the Honorable Head of Indonesia Health Minister, Mr. Insinyur Budi Gunadi Sadikin, CHFC CLU, and the Honorable Insinyur Rustian Un, MBA, CEO of PT Mitra Keluarga Karya Sehat Tbk, and the Honorable Dr. Esther Maria Ramono MM, as the Chairperson Yayasan Mitra Keluarga, and the last, the Honorable the Head of Stikes Mitra Keluarga, Dr. Susi Hartanti, SKP MKep, Spesialis Keperawatan Anak, and all of Stikes Mitra Keluarga lecture, and also presenter, participant of the second International Lighthouse Student Conference 2022. The second International Lighthouse Student Conference 2022 will be held for the next 2 days, from September 14 until 15, 2022. This conference purpose is to bring together academia, researchers, health entrepreneurs, practitioners, and policymakers who are responsible for delivering sustainable solutions through leveraging the advanced health sciences in nursing, nutrition, medical laboratory technology, and pharmacy. This conference provides a great opportunity for prospective participants to share their recent theoretical knowledge, recent findings, and experiences in dealing with health sciences. As such, this conference will feature presentation by internationally speakers which are cutting-edge session topics. Ladies and gentlemen, before we start the conference, I would like to deliver Stikes Mitra Keluarga Safety inductions during online meeting. First, this event has been conducted through Zoom applications where all participants join in home or workplace. So we would like to ask all of you to keep pay attention the visibility of your PC, laptop, or your mobile device. Second, please, we hope all participants keep paying attention to ergonomic aspect. Make sure your sitting positions are safe during the session. Third, keep attention to electrical hazards such as charger cable or around a switch around you. Fourth, if you attend the seminar together, don't forget to keep your physical distance. Fifth, make sure you know the evacuation route where you are. Six, make sure air circulation and lighting in your place comply with occupational health and safety standards. 7. Stay healthy during the COVID-19 pandemic and drink enough water. Practice 5M, which is wearing a mask, hand washing, physical distancing, avoiding crowd, limiting mobilizations. Excellencies, participants, ladies and gentlemen, we are now going to sing our national anthem, Indonesia Raya. Excellencies, participants, ladies and gentlemen, we are now going to listen to the conference report delivered by the chairperson of the Second International Allied Health Student Conference 2022. Ladies and gentlemen, please welcome Mr. Nur Andrian Ilsan, PhD.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Good morning. Our honorable guest, our Minister, Indonesian Health Minister, Mr. Insinyur Budi Gunadi Sadikin, CHFC CLU, Insinyur Rustian Un, MBA, CEO PT Mitra Keluarga Karya Sehat Tbk, Dr. Esther Maria Ramono, MM, as a chairperson of Yayasan Mitra Keluarga. Also, Dr. Susi Hartati, SKP, MKAP, spesialis keperawatan anak, as a head of Stikes Mitra Keluarga. Thank you for joining us in our annual conference Second International Allied Health Student Conference that be held by Stikes Mitra Keluarga. Also, thank you for all of Indonesian and international expert speakers in this conference. This conference entitled Health Innovation for Strengthening Global Health. Me, as the chairperson of this activity of this conference, will report the attendance registered so far. As many as 550 participants in this conference already registered, including 52 oral presenter in the second day, either from Indonesian or international author. Again, thank you for joining us and hope we can discuss about the health innovation in this event. Thank you very much.
Thank you, Mr. Nur Andrian, for the report. Excellencies, distinguished guests, participants, ladies and gentlemen, now we are going to listen to the welcoming speech delivered by the head of Stikes Mitra Keluarga, Dr. Susi Hartati, SKP, MKep, Spesialis Keperawatan Anak. Ladies and gentlemen, please welcome Dr. Susi Hartati.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Your Excellency, Mr. Insinyur Budi Gunawan Sadikin, CHVFC, CLU, Indonesian Health Minister, Mr. Insinyur Rusdian Pun, MBA, CEO of Mitra Keluarga Karya Sehat Tbk, Dr. Esther Ramono, MM, Chairperson of Mitra Keluarga Educational Foundations, dear colleagues, professors, lecturers, researchers, ladies and gentlemen. On behalf of Stikes Mitra Keluarga, I would like to express my sincere gratitude and welcome you to the Second International Allied Health Student Conference. Moreover, I honorably welcome our keynote speaker, Mr. Insinyur Budi Gunadi Sadikin, Indonesian Health Minister. Recently, Indonesian higher education has become a place for sharing and developing science and technology. We as an academic institutions are responsible in education, research, and community engagement, of which we call them to Tridharma Perguruan Tinggi. Our beloved institution, Stikes Mitra Keluarga, is holding the annual conference of the Second International Allied Health Student Conference 2020 by bringing health innovation for strengthening global health theme. This event will share several innovations in health sector, including nursing, nutrition, medical laboratory technology, and pharmacy. Innovation is something that can make human life better, whether it will be a new product, a new concept, or an improvement that makes it better for human life. Health is the most important aspect of our entire life. The speech will be presented by both our colleagues from Indonesia and international experts from Japan, Taiwan, Thailand, and Bangladesh. I hope this conference will motivate, inspire, and encourage us to become more innovative in all aspects of life. I believe this conference will continue to serve a meeting platform for the researchers, academicians, health practitioners, and students from all around the world. I also would like to acknowledge this conference as one of the medium to discuss and share current topics in scientific development. It presents a remarkable opportunity to exchange knowledge in many aspects and to create and renew a global network of colleagues. Furthermore, I would like to thank all the authors, keynote speakers, and panelists for making great effort of sharing innovative minds and research results, and with all the participants, academic, industry communities. Last But not least, my deepest gratitude goes to the advisory board, organizing committee, international scientific committee, institutions, corporate company, and volunteers who have directly and indirectly supported this conference. We are looking forward to warmly welcoming you to the conference. May God bless us all with good health to make this event a successfully and enjoyable one. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Susi Hartati, for the welcoming speech. The next welcoming speech is from Dr. Esther Maria Ramono, MM, as Chairperson of Yayasan Mitra Keluarga. Please welcome Dr. Esther Maria Ramono.
Masih di mute, Dok?
Excellency Minister of Health, Insinyur Budi Gunadi Sadikin, CH, FC, CLU, Head of Stikes Mitra Keluarga, Dr. Susi Hartati, SKEP, MKEP, SPKEPAN, Researcher, BRIN, Department Researcher, Center of Microbiology, Applied, Dr. Is Helianti, MSc, Mrs. Agustina Maya, as Pharma Business Development, Kalbe, Mr. Nur Andrian Ilsan, PhD, as the Chairman of Second IAHSC Committee, and all speakers that I couldn't mention one by one. Respectable, all of the committee, participant, and oral presenter for the Second International Allied Health Student Conference. Pak Rusdian apologized that he cannot join us today. First of all, thanks God we can attend and gather by Zoom in good condition and situation. This is the second International Allied Health Students Conference that held in Stikes Mitra Keluarga. The theme we raised in this conference is health innovation for strengthening global health. We are glad that there are many enthusiastic to this conference, even from domestic and foreign. Innovation is a creation, development, and implementation of a new product, process, or service with the aim of improving efficiency, effectiveness, or competitive advantage. As we know, World Health Organization has a vision driving innovation in health approach to build global innovation in health movement to accelerate the achievement of health for all and health-related sustainable development goals. We hope this conference can inspire and motivate to make innovation in research development, especially in health issues. I hope all participants will enjoy this seminar. Thank you. I return to the Master of Ceremony.
Thank you, Dr. Esther, for your welcoming speech. Before continuing to the next agenda, now we are listening our keynote speaker, the Honorable Head of Indonesia Health Minister, Mr. Insinyur Budi Gunadi Sadikin, CHFC CLU, and will be moderated by Mrs. Nurse Rohayati, SKEP MKEP, Spesialis Keperawatan Komunitas. For Mrs. Rohayati, please, it's your time.
Thank you, Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Good morning, all of participants. The Honorable Indonesian Ministry of Health, Mr. Insinyur Budi Gunadi Sadikin, CHFC CLU. The Honorable Mr. Insinyur Rustian Un MBA, as CEO PT Mitra Keluarga Karya Sehat Tibika. The Honorable Dr. Esther Maria Ramono MM, as Chairperson of Mitra Keluarga Education Foundation. The Honorable Dr. Susi Hartati, SKP, MKep Spesialis Keperawatan Anak, as Head of Mitra Keluarga School Health Science. All colleges, professors, lecturers, researchers, ladies and gentlemen, welcome back to the second International Allied Health Students Conference 2022. My name is Rohayati, and I'm going to be the moderator for this session. Health innovation is a new or improved solution with the transformative ability to accelerate positive health impact. In line with our institution vision, Stikes Mitra Keluarga, that is, menjadi institusi pendidikan tinggi kesehatan yang inovatif di tingkat nasional pada tahun 2035. Innovation is very important for high quality healthcare. And I'd like to greet our keynote speaker, Indonesian Ministry of Health. Hello, Mr. Insinyur Budi Gunadi Sadikin, CHFCCLU. Are you with us? Good morning, Mr. Budi. Are you with us? Hello, good morning, Mr. Budi Gunadi.
Sorry, Ms. Rohayati, until we waiting the Honorable Mr. Insinyur Budi, we are going to play the music first. Mr. Budi Gunadi will joining us in 10 minutes or 15 minutes. Thank you.
Okay, thank you, committee. So I'm so sorry, ladies and gentlemen, all participants. We are going to wait for Mr. Budi Gunadi for the moment. Good morning, Mr. Budi. Are you with us? Good morning, Mr. Budi Gunadi. Are you still with us?
Stikes Mitra Keluarga adalah sekolah tinggi ilmu kesehatan yang modern, komprehensif, multibudaya dalam disiplin ilmu kesehatan yang terkemuka di Indonesia. Kampus Stikes Mitra Keluarga terletak di Bekasi Timur, di sebuah kawasan strategis yang mudah diakses dan menyatu dengan Rumah Sakit Mitra Keluarga Bekasi Timur. Tuntutan akan kebutuhan pelayanan kesehatan yang profesional sesuai dengan kemajuan ilmu dan teknologi merupakan motivasi yang kuat untuk Yayasan Pendidikan Mitra Keluarga dalam menyelenggarakan pendidikan kesehatan. Diawali dengan berdirinya Akademi Keperawatan sejak tahun 1993, Yayasan Pendidikan Mitra Keluarga dengan perjalanan waktu saat ini menjadi Sekolah Tinggi Ilmu Kesehatan Mitra Keluarga dan berhasil mendapatkan akreditasi dari Badan Akreditasi Nasional. Yayasan Pendidikan Mitra Keluarga berada dalam naungan Mitra Keluarga Group yang memiliki beberapa rumah sakit yang tersebar di daerah DKI Jakarta, Jawa Barat, Jawa Tengah, dan Jawa Timur. Dengan didukung oleh pengajar yang berkualitas dan fasilitas lengkap, Stikes Mitra Keluarga mempunyai visi menjadi institusi pendidikan kesehatan yang unggul dalam tata kelola pendidikan pada tahun 2020 dan menghasilkan lulusan yang berkompeten dan unggul di bidang kesehatan. Misi Stikes Mitra Keluarga menyelenggarakan pendidikan, penelitian, dan pengabdian kepada masyarakat secara profesional sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Meningkatkan kesadaran masyarakat terhadap peningkatan derajat kesehatan melalui kegiatan pengabdian kepada masyarakat, serta mengembangkan dan meningkatkan kerjasama dengan lembaga lain di dalam maupun di luar negeri untuk pengembangan ilmu pengetahuan dan teknologi di bidang pendidikan kesehatan. Berdasarkan survei, sebagian besar alumni lulusan Stikes Mitra Keluarga mendapatkan pekerjaan pertama dalam waktu kurang dari 1 bulan sebanyak 64%. Sebuah prestasi yang membanggakan dan menggambarkan tingginya kebutuhan tenaga kesehatan di Indonesia.
Dalam menghadapi tantangan di era global ini, Stikes Mitra Keluarga bertekad untuk membangun pendidikan tinggi berkualitas agar lulusannya dapat bersaing dan terima di pasar global. Pendidikan tinggi yang berkualitas merupakan pendidikan yang menghasilkan lulusan yang mampu secara aktif mengembangkan potensinya dan dapat menghasilkan ilmu pengetahuan dan teknologi yang berguna bagi masyarakat, bangsa, dan negara. Menghadapi tantangan tersebut, Stikes Mitra Keluarga memiliki visi menjadi institusi pendidikan kesehatan yang unggul dalam tata kelola pendidikan. Membangun tata kelola perguruan tinggi sangat penting, baik dari sisi penjaminan mutu, transparansi, keadilan, tanggung jawab, tanggung gugat, efektif, dan efisien. Dalam membangun tata kelola yang baik tersebut, Stikes Mitra Keluarga selalu menciptakan suasana akademik yang kondusif. Oleh karena itu, penyediaan sarana prasarana menjadi prioritas kami untuk mendukung proses pembelajaran yang berkualitas. Stikes Mitra Keluarga selalu melakukan koordinasi dengan Kopertis Wilayah 3 Jakarta, Kemenristekdikti, dan lembaga akreditasi. Mari bergabung dengan Stikes Mitra Keluarga, the best health education for your bright future.
Saat ini Stikes Mitra Keluarga memiliki 5 program studi, antara lain Program Pendidikan Vokasi, D3 Keperawatan, D3 Teknologi Laboratorium Medik, Program Pendidikan Akademik Sarjana, S1 Gizi, S1 Farmasi, S1 Keperawatan dan Nurse. Program studi D3 Keperawatan berorientasi menyelenggarakan pendidikan Diploma 3 yang unggul dalam penguasaan, pengembangan, dan aplikasi ilmu dan teknologi secara profesional dalam bidang keperawatan untuk pembangunan masyarakat berkelanjutan. Program studi D3 Teknologi Laboratorium Medik berorientasi menyelenggarakan pendidikan Diploma 3 yang unggul dalam penguasaan, pengembangan, dan aplikasi ilmu dan teknologi secara profesional dalam bidang teknologi laboratorium medik untuk pembangunan masyarakat berkelanjutan. Program studi S1 Gizi berorientasi menyelenggarakan pendidikan sarjana strata 1 Gizi yang unggul dalam penguasaan, pengembangan, dan aplikasi ilmu dan teknologi secara profesional dalam bidang gizi untuk pembangunan masyarakat berkelanjutan. Program studi S1 Farmasi memiliki visi menjadi penyelenggara program pendidikan sarjana farmasi yang bermutu dan menghasilkan lulusan yang unggul dalam farmasi klinis, serta berorientasi pada peningkatan kesehatan pasien dan masyarakat. Program studi profesi nurse merupakan pendidikan akademik profesional dengan proses pembelajaran yang menekankan pada tumbuh kembang kemampuan mahasiswa untuk menjadi seorang akademisi dan profesional. Fasilitas yang dimiliki oleh Stikes Mitra Keluarga antara lain ruang kelas multifungsi, ruang teater, auditorium, laboratorium lengkap, laboratorium komputer, perpustakaan,
Ladies and gentlemen, and all colleagues and participants, I would like to apologize that Mr. Budi Gunadi Sadikin still not joined with us until now. So we are going to start the first session for plenary session. We have 3 speakers from various health fields who are already with us. The first speaker is Prof. Thierry Pierre-Robert Bernau from College of Biomedical Engineering, Taipei Medical University, Taiwan. Good morning, Prof. Thierry.
Morning.
Okay. Then the second speaker is Dr. Susi Hartati, SKPM Spesialis Keperawatan Anak from Stikes Mitra Keluarga. Good morning, Dr. Susi.
Good morning, Mr. Wahyati. Good
Okay,
morning, Prof. Taylor.
And the third speaker is Mrs. Agustina Mayasari. Mrs. Agustina Maya, SSI APT from Pharma Business Development at Kalbe. Good morning, Mrs. Agustina.
Good morning, Ms. Atim. Good morning, everyone.
Ladies and gentlemen, our morning presentation will going 2 hours. But when Mr. Budi Gunadi Sadikin is join with us, maybe I will take a part for Mr. Budi. So each speaker in plenary session will present around 30 minutes. After 3 speakers presented the topic, we will open discussion session about 30 minutes. All the audience can ask a question. If you have a question, you can ask your question during the session by typing your question in chat room, either in English or in Bahasa, no matter. If you are ask a question in Bahasa, I'll translate it for you. Or you can raise your hand when the discussion session begins. Now we are going to the first speaker. I'm going to invite Mr. Prof. Thierry Pierre-Robert Bernau. I'd like to read your profile first. Committee, can you share the PPT of Prof. Thierry CV? Prof. Thierry Bernau, PhD in biochemistry, graduated from University of Lille, France, and postdoc from Northern Regional Research Center, USDA, Illinois, USA. Professor leads a research unit on platelet lysates and extracellular vesicles for regenerative medicine, cell therapy, and novel practitioner technologies of immunoglobulins. He got awarded the Taiwan Ministry of Science and Technology Outstanding Research Award in 2021. Over 300 scientific SCI publications on plasma products, purification, and virus reduction treatments, and platelet lysates for cell therapy and regenerative medicine. Wow, really great work. The 300 scientific publications. Okay, Prof. Thierry Bernau will present his work with title Human Platelets for Regenerative Medicine. Prof. Thierry, would you like to share your presentation by yourself or by committee?
I will try to share by myself. Can you see it?
Yes, I see. All right, it is your turn to present your work. You have 30 minutes. The screen is
thank you very
yours.
much. Thank you for the introduction, and it's impressive to see so many people attending this meeting. So I'm very happy to join the International Allied Health Science Conference, and I want to thank in particular Dr. Noor Adrian, who I had the pleasure to meet in TMU, in Taipei Medical University. So the topic I have been asked to talk about today is human platelet for regenerative therapies. I would like to see whether you can see my arrow. Can you see it when I touch the screen? Okay. Maybe you can see the laser pointer. A talk about human platelets for regenerative therapies, and I put here the learning points I would like to share with you in this presentation. And the first one is the fact that platelet concentrate, which probably you know they are used in the hospital to treat patients who have thrombocytopenia or dysfunction of their platelet. This platelet concentrate can be used also now. It's a field which is emerging for new therapeutic application in regenerative medicine and cell therapy. Another point I would like to indicate, I mean, maybe some of you have heard about platelet-rich plasma, which is typically a product from autologous source. There is a trend toward the use of allogenic platelet concentrate for application in regenerative medicine in cell therapy, which means that in this type of thing, the platelet concentrate collected from blood donors, like in Indonesia by Indonesian Red Cross, could be used for this application where they are not used for transfusion. And in particular, because the so-called outdated, expired allogenic platelet concentrate can still be used for some of these applications in regenerative medicine, while they are currently discarded when they reach the expiry date, which is typically 5 or 7 days. They are currently discarded, but they can be stored and used for other type of clinical applications. So these are basically the learning points of this presentation. So the allogenic platelet concentrate collected from blood donors, there are two types of procedure which can be used to generate the platelet concentrate. Either the donors are giving whole blood, which is subsequently centrifuged to isolate the platelet material, platelet concentrate, or dedicated apheresis donation procedure can be implemented in order to specifically collect the platelet concentrate, and the red blood cell are returned to the donor. So what I'm going to say applies to both platelet concentrate from whole blood donations and platelet concentrate obtained by apheresis donation. So you know that the allogenic platelet in transfusion medicine can be used for transfusion as a therapeutic treatment or for prophylactic treatment in the case of thrombocytopenia when patients have a low platelet count, or they can be used also to treat patients who have a platelet dysfunction, difficulty to aggregate or to exert their hemostatic properties. So the talk here will address the other application of the allogenic platelet concentrate, as I said, it's something which is emerging. And the application covers the field of cell therapy, as you will see, and treatment of direct applications in regenerative medicine. So the allogenic platelet in medicine, I mean, now we are going to distinguish two types, the fresh platelet concentrate, which are used for transfusion, and typically these are platelet concentrate which are expired after 5 or 7 days, depending upon the procedure used or the legislation. And this expiry time, which is quite short, is mostly linked to the fact that there is a risk of bacterial contamination during the collection procedure of the platelet concentrate. But yes, hello.
I'm sorry, Prof. It's yeah, the sound is coming maybe because they are unmuted. Just please continue your presentation.
Okay. Thank you. I'm sorry. And then, so these platelet concentrate after 5 or 7 days after collection are considered to be outdated but that can actually be used for further processing, a bit like plasma for transfusion can be used for fractionation to get different type of medicinal product, because these outdated platelet concentrates still contain functional molecules which can be used for other clinical applications. So the use of autologous platelet in medicine have been developed for many years now. You heard about PRP, platelet-rich plasma, where the blood is taken from the patients themselves in order to isolate a fraction which is enriched in platelet and which is called platelet-rich plasma. So a number of the applications in the field of medicine and application with allogenic platelet concentrate are inspired by what is known by the use of PRP. But PRP has been, in a way, criticized because there are different types of procedures used to collect the PRP, different types of medical devices. So there are sometimes inconsistency in the use, but still it is recognized that these type of materials from the autologous platelet can be used potentially, or can be used to treat osteoarthritis, at least for their analgesic effect, decrease the pain. They can be used for treatment of ocular disorder, in particular dry eye syndrome. They can be used for the treatment of recalcitrant ulcers, or they can be mixed with implants for bone reconstruction. So what we are seeing in the field of allogenic platelet concentrate is inspired by what has been developed with PRP. So why platelet can be used for cell therapy and regenerative medicine? I think there are two objective reasons. The first one is that platelets are the healing cells of our body, and I'm going to explain this in the next few slides. And also there is an infrastructure already in place for the collection of allogenic platelet concentrate by blood establishment, Indonesian Red Cross, for instance, in your country. And therefore, this is a good rationale for looking at new applications of platelet in regenerative medicine and cell therapy. So let's focus first on the first point, the platelet, which are healing cells in our body. This is a drawing which represents, to some extent, what is a platelet. So the main feature which you can have in mind is the fact that platelets are relatively small cells in our body compared to white blood cell or compared to red blood cell, which are 5 to 10 times bigger. They don't have a nucleus, although they can perform some limited protein modification or synthesis. They have an interesting feature which is called the open canalicular system, which allows a communication between the inside of the platelet, in particular alpha granules, and the blood environment, and which allow the platelet to store some factors which are not synthesized by the megakaryocyte. And so there is this exchange between the inside of the platelet and the outside environment. There are in platelet different type of granules, in particular the alpha granules, and we have roughly 50 to 80 alpha granules within each platelet. You have the dense body or the dense granule, 3 to 8 per platelet. You have mitochondria in the platelet, 1 or 2 relatively small mitochondria. And you also have a structural protein which helps to maintain the structure of the platelet. Typically in our body, the platelet have an oval shape under their quiescent state, but they also have the capacity to activate and increase in size and form pseudopod when they are activated and start to degranulate, start to release their content. So this structural zone is important to allow the exchange and the release of factors from the platelets. If we go into a little bit more details into the content of the platelet, so you can see there is a lysosome as well as a granule with a glycolytic and proteolytic enzyme. You see the dense granule, which contain ADP, ATP, calcium, so there is a source of energy for the platelets. And interestingly, the platelet also contain a number of compounds which are considered to be neurotransmitter. They can also play a role in thrombosis. And then you have the alpha granule with, which are very complex with coagulation factor adhesion molecules, immunological molecules, as well as chemokines and regulator of growth and angiogenesis. And this is the reason why there is big interest in the platelet as a source of growth factor, a source of chemokine and cytokine, which can be useful in regenerative medicine and tissue repair. So let's look at what is taking place in our body when in the blood circulation. You have here a picture of platelet when you can see the granules inside them. And when we look at the content of the alpha granules, you will see that there is a number of growth factors which are contained within the alpha granules, including some which probably are not synthesized by the megakaryocyte, like a brain-derived neurotrophic factor, which is likely entrapped, loaded within the platelet from the blood circulation. But so when the platelets are activated in the blood circulation, if you hurt yourself, if you have a vascular injury, there is a process which leads to the synthesis of thrombin, which is going to convert fibrinogen into fibrin, the fibrin clot, but also the thrombin participate in the activation of the platelet. And this activation of the platelets, as we said before, leads to the release of the growth factor and other factors contained into the alpha granules, so they can combine with the fibrin network, which you can see here, so produced by conversion of fibrinogen into fibrin by the thrombin. So you have here a scaffold which contains growth factors. All these growth factors can also be released by extracellular vesicle, which has kind of liposome released by platelets with a bilayer and a size of about 200 nanometers, and which can serve for cell-cell communication, because these extracellular vesicles can be internalized by target cells, and they express a number of receptors on their membrane. So having said that, if we come back to what is taking place in the blood establishment, so we collect platelet concentrate from blood donor. If they are not used for transfusion, they can be frozen, or they can be activated by calcium chloride to activate the coagulation cascade and release thrombin. And then you get a platelet lysate suspended in the plasma compartment, which contain multiple proteins. So the plasma compartment means that you have a high protein content. You have albumin, which is the major protein in the plasma. You have immunoglobulin, you have fibrinogen, if you don't activate by calcium chloride, and you have IGF-1, which is a growth factor, insulin-like growth factor, which is mostly present in the plasma. And then you have a number of growth factors coming also from the platelet, like the one you can see listed here. You saw them in the previous slide. And you can see that the content is quite substantial in nanogram per ml. So a high content in growth factor suspended in plasma when you get the platelet concentrate suspended into the plasma. So if we look at into more details about what these platelet lysate contain, so they have growth factor, they have factors which are known to be anti-angiogenesis, but you have also factors which can stimulate angiogenesis. You have some chemokines which have been proven to be good for neurogenesis. you have antioxidant in the platelet lysate, you have anti-inflammatory factor, and you also have factors which are neurotransmitter. So you have a cocktail of molecules which can have very, very interesting properties to activate complementary signaling pathways of interest in regenerative medicine, in tissue protection, the skin, the bone potentially, and we will discuss this a little later, also for brain and for neuroprotection. So what are the new field of application of allogenic platelet? Sorry, it's concentrate, not this is French word. So what are the new field of application? Typically, right now, we can see three fields of application of outdated platelet concentrate or outdated platelet lysate from blood establishment. One is for human cell propagation for transplantation. One is as a direct clinical use, and the other one is for a source of extracellular vesicle, which is a field of big interest nowadays for regenerative medicine as well as for a drug delivery vehicle. So you see application in cell therapy, application for regenerative medicine, and here application for regenerative medicine and drug delivery systems. So let's go into details into these different type of application. Then let's also discuss about some quality and safety specification for these products. So HPL means human platelet lysate. Let's look at their use for human cell propagation. The field which is developing now is in the field of clinical grade human cell propagation for transplanting cells. The interest is based on the fact that if you use human platelet lysate, you can have growth medium to expand cells like stem cell, which will be seen as xeno-free. So no use of compounds, of growth factor, of nutrients coming from animal sources like bovine sources. So this can serve as a substitute for fetal bovine serum, which so far has been the gold standard for propagation of cells ex vivo. And the use of a human material can help to avoid immunological or infectious risks coming from animal sources. So how is it done? So basically you have a system where blood establishment here, like Indonesian Red Cross, collect the platelet concentrate from whole blood donation or from single donor apheresis procedure. If they are not used for transfusion, they can be stored instead of being discarded. And then you can freeze them at -30 or colder. And then you can supply this material to a maker of human platelet lysate, which is going to pool typically different number of platelet concentrate together, do a sewing, have some limiting processing step to filter, remove cell debris, and then aseptic filtration to remove bacteria, and then they can dispense these platelet lysate into different bottles, which can be provided to the HPL user, which can mix this with the growth medium in order to expand cells, which can be transplanted into patients. So what do we know about these applications? The capacity to use human platelet lysate to expand mesenchymal stromal cells has been developed more than 10 years ago already. And all the data which we have accumulated now are showing that this is truly a very good substitute for fetal bovine serum to expand different type of stem cell coming from different type of tissues. And the data are convincingly showing that HPL used at a lower percent than fetal bovine serum in the growth medium. So typically 5 to 10% instead of 10 to 15% give data for the expansion of mesenchymal cells, which is at least as good as or typically better than what you can get with FBS. So in a nutshell, you get more cells in a shorter period of time and these cells keep their properties of being mesenchymal stromal cells. The other field which we see developing now is the use as well of this human platelet lysate as a supplement of growth medium to expand chondrocyte or corneal, epithelium, endothelium cell, potentially tenocyte, as well as immunological cells, including T lymphocyte and CAR T cell. There are some papers showing that use of HPL can have some advantages for the efficacy of CAR T cells. So this means that there is a strong development of human platelet lysate in this field of application for cell therapies. And actually, if you look at what is on the market, you will see that there are companies already providing or marketing human platelet lysate for this type of use. I don't know whether I will go into some details in this slide, but basically what should keep in mind that there may be some variation in the type of material, type of human platelet lysate, which can be used for human cell propagation. So these are points to keep in mind and to consider when selecting a human platelet lysate. And I personally believe that for cell culture and cell expansion, we need to have dedicated products which are more suitable for application, and in particular for expanding differentiated cells. The type of platelet lysate can be quite important. So some factors are linked to the collection procedure of the platelet concentrate, and other are linked to the mode of production of the human platelet lysate by the HPL manufacturer. So now let's move to the second type of application, which is the use of allogenic platelet lysate made from PC collected by blood establishment and for direct clinical use. And as I indicated in my initial part of the talk, these indications are currently much influenced by what is done with platelet-rich plasma of autologous origin, which can be used for treatment of diabetic ulcer, treatment of osteoarthritis, treatment of dry eye syndrome, implants, and also a number of additional applications, which for some of them are not completely proven yet. So this is something we should keep in mind. So when it comes to allogenic platelets for direct clinical application, what is the status now? There are already a number of blood establishments in the world which are preparing allogenic platelet lysate for treatment of various types of ocular disorder as an eye drop, in particular in patients who, for a number of reasons, cannot give or cannot donate their own blood. For those who want to have additional information, they can go on the website of the International Society of Blood Transfusion, because we organized a symposium, a workshop not long ago, and there are some information on the website, and this is freely available. I believe that there will be applications with allogenic platelet lysate, which will cover the application developed already for autologous platelet lysate, but we are likely to see additional and emerging work being done, as I mentioned before, for the treatment of disease of the central nervous system. And my lab in Taipei Medical University is focusing on this aspect together with teams in Australia and in France. So we see application of this material for joint administration, for osteoarthritis, topical for treatment of ocular disease, and also we are working on intranasal, intracanal, intracerebroventricular administration in animal models for treatment of central nervous system. And finally, I would like to say a few words about the use of this allogenic platelet lysate as a source of extracellular vesicles sometimes known as exosomes, but exosomes are now recognized as only one part of the extracellular vesicle released by cells. If you look at the platelet concentrate coming from the blood establishment, they contain a lot of extracellular vesicle, 10 to the 11, 10 to the 12 per ml, or at least these are events which looks like being extracellular vesicle. And if you look at the collection process of the platelet concentrate, so we can imagine that part of these EVs, extracellular vesicle, are coming from the blood circulation, because in our blood, roughly 50% of circulating extracellular vesicle are coming from platelets and megakaryocytes. But also we know that there are EVs which can be generated during the collection of blood or the processing of the platelet concentrate. So collection procedure can induce an activation of the platelet and release of extracellular vesicles. Some filtration procedure can have an impact. Pathogen reduction, when it is performed, can also contribute to having an impact on the content or type of extracellular vesicle. And the storage of the platelet concentrate for 5 to 7 days is also a step which can lead to a release of extracellular vesicle from platelets. So these extracellular vesicles include exosome, microvesicle, apoptotic bodies. These are vesicles of size of 50 to 800 nanometer, roughly, slightly negative charge, and they express receptors and ligands, which are basically the same as the one expressed by quiescent platelet or activated platelets. So these extracellular vesicles from platelet are important for cell-cell communication as a cargo of trophic factors or microRNA, and it is known that these extracellular vesicles have a good capacity to cross tissue barriers and to be internalized by target cells. So this is why one can expect they can be useful for regenerative medicine and also as a drug delivery carrier. So indeed, right now we have studies being done in laboratories to better characterize the extracellular vesicle from platelet concentrate, to develop technologies to be able to isolate these extracellular vesicle for potential preclinical and clinical applications. We also have work being done to determine better the safety profile of these extracellular vesicle from the platelet. And I think something which would be very interesting is to compare the properties of the extracellular vesicle from platelet to those which can be released from mesenchymal stromal cells in culture. And some other aspect also look at evaluation in preclinical models, cellular models, and animal models in order to define what can be the clinical application of these extracellular vesicles, in particular for regenerative medicine. If you want to have more details, you can look at this paper we published recently in Trends in Biotechnology, but basically we explain why so-called naive extracellular vesicle, which means that it's just the extracellular vesicle are isolated from platelet concentrate, and they are used as such for testing for age-related degenerative disorder, treatment of skin wound, eye disorder, brain disorder. And we also have studies which are being done to look at the capacity to use these platelet extracellular vesicle as a drug delivery carrier. I mentioned cancer here because it is known that there are crosstalks between platelet and cancer. Platelet can be retained in the tumor microenvironment. When they are in the tumor microenvironment, they can activate themselves, and if they are activated, they release their content. And if we load anti-cancer agent within platelet or extracellular vesicle from platelet, there is a hope to be able to release the cancer drug in the tumor microenvironment. The other point, which it's a reminder that it's important to ensure the safety of platelet material for use for these applications. So there is an infrastructure in place. One aspect which is particularly important is the fact that these platelet concentrate for these applications should meet the same quality criteria for transfusion. So all these steps important for the safety and quality of platelet for transfusion should apply also for platelet for regenerative medicine and cell therapy, and particularly in terms of viral safety. All the measures which are in place to ensure the safety of platelet concentrate for transfusion, as the one you can see here, should be applied for the preparation of platelet lysate from the platelet concentrate coming from the blood establishment, and with the importance of having a good regulatory overview of the collection of platelet for applications for regenerative medicine and cell therapy. I put here a number of papers which you can look at if you want further details. And with this, I will come to the slide of take-home messages. So what we try to say in this presentation is that pooled human platelet lysate and derivatives like extracellular vesicle have a strong potential as ancillary materials, which means as supplement for expanding cells, and this is already demonstrated. And they have also potential to be used as medicinal product for regenerative medicine. There is a need for detailed quality control specification of pooled human platelet lysate, and this will depend upon the type of clinical application and the mode of administration of the platelet lysate. If you infuse to the brain or if you apply on the skin, the quality criteria may not be the same. Viral safety is something which is important for pooled human platelet lysate. So the measures in place in blood establishment must be applied, as we mentioned, and potentially if the pool of platelet concentrate is large, additional pathogen reduction treatment or virus inactivation treatment can be implemented by the maker of the human platelet lysate, because various safety measures for pooled human platelet lysate are expected to be the same as the one which are in place already for the plasma product industry. I know that Indonesia is interested into plasma fractionation to have access to coagulation factor, immunoglobulin, albumin, and other products. And the making of this product is very much regulated, and the selection of the virus safety measure and viral inactivation treatment is crucial to these products. I will end up by thanking the students in my lab who have been generating some of the data I presented here, and some of my colleagues internationally with whom we are collaborating, and the granting agencies which are supporting the research work in my lab. Yeah, thank you very much for your attention.
Thank you, Prof. Thierry. Such a wonderful presentation. I'm sorry, I would like to open the discussion for you because I see there's so many questions in the YouTube chat room and one question in the Zoom chat. The first question I will read come from Zoom chat room. Yeah, the question come from Dito Anurogo, Taipei Medical University, Taiwan. Yeah, Dito said, it is really amazing and inspiring presentation. I have two questions for Professor. The first question is, what are the fundamental roles and features of the platelet, proteome, and extracellular vesicles for the development of novel neuroprotective and neurogenerative intervention to manage various neurodegenerative disease and disorders?
So I answer this question first. But
Okay.
platelets are typically known as cells which are important for hemostasis, right? That's what is known about platelets. But as I tried to indicate that when they granulate, they release a number of growth factors. And these growth factors are very complex, and these factors are very complex. So why they can be used for application for the treatment of neurodegenerative disorder. I think that we realize now, I mean, people are working on treatment for Parkinson's disease, for Alzheimer's disease, for stroke, for traumatic brain injury, for Huntington disease. But I think it's very important to realize that probably one single molecule is not going to be able to treat such complex disease, where neuroinflammation in particular is very much involved into the occurrence or development of neurodegenerative disease. So the platelet lysates are to be considered to be like a biotherapy, where you can administer to the brain a cocktail of neurotrophins. So you have PDGF, you have BDNF, you have VEGF. Then you also have antioxidants, which are very important for some neurodegenerative disease. You have GPX4 in the platelet lysate, you have catalase in the platelet lysate, and you also have anti-inflammatory factors. So all these combination is probably what is the reason why the platelet lysate can have beneficial impact on neurodegenerative disorder, and the preclinical studies we are doing in animal models for Parkinson's disease, for traumatic brain injury, for amyotrophic lateral sclerosis are showing an effect in animals.
Okay. Mr. Dito, are you with us? Mr. Dito is
Yes,
yeah.
I'm
Do you got the answer from Prof. Thierry for the first question?
yes. And the next how to combine them, Professor, with the immunotherapy or cell therapy to improve the safety and efficacy. Thank you.
Okay. The second question from you, Mr. Dito, to Professor is how to combine the platelet proteome and extracellular vesicles with the immunotherapies or cell therapies such as stem cells, short cell therapy, nanoparticle, abdomen, etc., to improve the safety and efficacy of neurodegenerative disease management? That's the second question from Dito.
Okay, so I think the question is focusing on the combination of mesenchymal stromal cells treatment and treatment with platelet lysate and extracellular vesicle. So the first aspect where platelet lysate are useful is for the expansion of mesenchymal stromal cells to make them safer, because it has been shown that when you expand the cells, mesenchymal stromal cell with fetal bovine serum, actually you have an internalization of proteins from bovine origin and internalization also of extracellular vesicle, which are present in the fetal bovine serum you use to expand the cells. So this can lead to immunological disorder, because if you transplant cells which have protein coming from bovine origin, the patients may develop an immunological reaction to the small amount of bovine protein which have been entrapped by the stem cells. So this is one obvious aspect when the human platelet lysate can be useful, and also for aspect related to risk of transmission of prions from the fetal bovine serum. The other point where maybe there can be complementarity for treatment of neurological disorder is, I mean, you know, there are some work being done trying to transplant mesenchymal stromal cells for treatment of neurodegenerative disorder like Alzheimer's disease or Parkinson's disease. But the data are showing that actually probably the stem cells do not survive very long after transplantation, and they can be useful because they release themselves trophic factors. So I guess a comparison between the trophic factors from stem cell and those from platelet lysate would be very interesting to do. Where the platelet lysate can be useful is the fact that when you transplant stem cell, you do not control very well the dose of trophic factors you administer to the brain. When you administer a protein solution like platelet lysate, you have ways to do quality control, to determine the protein content, to determine the trophic factor content if you select a number of them, and you can adjust and control the volume of platelet material you administer to the brain. So in a way, you have a chance to have a more standardized, a better monitored application when you administer a protein solution compared to cells. But combining the two may be another option.
Okay, thank you for your answer. Mr. Dito, you got it?
Yes, it's very clear, Professor. Thank you for your enlightenment.
You can come to see me on 6th floor. We can have further discussion.
Okay.
Okay.
Thank you, Professor.
Actually, Mr. Dito, your student, all right, Professor? Okay. They are all participants, ladies and gentlemen. Maybe some of you want to ask the professor live streaming. Please, you can open your microphone and you can raise your hand so the committee will take you, will pin you. If there is no question live, I will read in the chat room again. We have one question in the Zoom chat and 4 questions in the YouTube chat. I will read for you from YouTube. The question comes from Mrs. Reza. I'm sorry, Mr. Reza. I'm sorry, Mr. Reza. Mr. Reza asked, PRP on the treatment of osteoarthritis is still debatable. PRP in patient osteoarthritis of the knee and pelvis is not recommended. Is it that right? And why the reason?
So can you repeat I did not get I mean, I know it's about osteoarthritis and use of PRP for osteoarthritis, but the precise question is which one?
Okay, I see. Is that the PRP for osteoarthritis is still debatable or not recommended?
Well, I think that it depends on the countries. I know in Asia, the US, people are typically very keen to use PRP. It depends. In many countries, it's not reimbursed, so patient would have to pay for it. If you look at the literature and some control studies which have been made, the tendency now is to consider that the administration of PRP to the joint, in particular for osteoarthritis, has an effect on the control of pain. And this may be linked to the fact that the platelet lysate contain anti-inflammatory molecules. So there is now some sort of consensus on the fact that this mixture administered to the knee helps to control the pain. When it comes to the regeneration of the chondrocyte or cartilage, the situation is not clear. It's controversial. Some studies are showing beneficial effect on the long term after administration of PRP, and other studies do not find the same. Why? I think here we are having an issue with the variability in the type of PRP which is being used. In the lab, we are doing some work with different type of differentiated cells, and we see that the same product cannot be used for different type of cells. If we use, I mean, let's say corneal endothelium cell or corneal epithelium cell, we see that a particular type of platelet lysate is best, and we see that a heat treatment can be a good thing to improve the efficacy in vitro. With preclinical studies on the brain, we also see that a particular type of human platelet lysate is more suitable for brain administration and for neuroprotection. So I think that for the chondrocyte, the issue is the same. I believe strongly that for application in regenerative medicine, we need dedicated product. We cannot expect that one given type of platelet lysate, very complex, can treat everything from bone to cartilage to skin to eye to neuronal cells or muscle cells. So in conclusion, it looks like the application is good to control the pain. For cartilage regeneration, I think we did more work to define the optimal material for administration to the knee.
Okay, thank you for your answer, Professor. We still have 4 questions. Yeah, we still have 4 questions. I will read from the chat Zoom. The question come from Aisyara Yuliandari. Aisyara say about why PRP can have a number 5 times higher than the platelets in the blood circulation.
Okay, so I think the question is about the preparation of PRP or platelet concentrate. And if you look at the goal of preparing PRP or platelet concentrate, it is to have a product which is concentrated in platelets to have better efficacy, especially for transfusion and for hemostatic capacity, because you don't want to inject a volume which would lead to the overload of liquid to the patient. So there is, during the preparation of PRP and platelet concentrate, an enrichment in platelet, which is 3 to 5-fold, which explain why the content of growth factor in the lysate is higher 3 to 5 times in the platelet lysate compared to blood circulation. And further, if you do purification of the platelet, if you remove the plasma compartment, you can resuspend the platelet is an even lower volume, and thereby you can have even higher concentration of platelet growth factor in the product.
Okay, thank you. Aisyara, do you got the answer from Professor?
Yes, thank you, sir.
Welcome.
Okay. Okay, I will call the participant again. Is there any participant want to ask question directly to the professor by open mic and live? Yeah, while I wait from the direct question, I will read another question for you, Professor. The question come from YouTube from Mrs. Intan. Mrs. Intan said, I'm interested in that Frob theory explained. As I know, the PRP has been used in facial treatment. How the procedure of PRP for facial treatment works?
Yes, PRP has been used for facial treatment. I mean, it's sort of subcutaneous administration of the PRP, mostly for plastic or cosmetic applications. And here it is believed that one of the first reasons why it is used this way is for stimulation of fibroblast expansion. If you do indeed cell culture, and if you grow fibroblast in a medium which is enriched with PRP or platelet lysate, you have a stimulation of the growth of the fibroblast. So this is one basic reason why the PRP has been administered for facial treatment. The other reason, which has not been demonstrated yet, but when you administer PRP, you also administered a lot of extracellular vesicles, which themselves are carriers of microRNA or growth factors, so you can, in a way, impact the cell biology, and you can stimulate, or maybe you can have some, I hesitate to use the word, but maybe some rejuvenation of the skin through this application. But I think we should be careful. Again, I mean, there may be deviation in the use of PRP for this type of application, and studies are needed again here to determine the best product for skin or facial or cosmetic applications.
Okay. I hope Mrs. Intan can get your answer in the YouTube. Yeah. Because the topic is very interesting, so the question is so many, Professor. Yeah, I would read another question come from Fasya Algina. Fasya ask you about, does PRP treatment have any side effects that dangerous and specific to the human body?
I think typically it depends on the type of PRP. If you administer a PRP which contains intact platelet or cell debris, you have to be careful about immunological reaction, because platelets can have antibodies, antigen on their surface. So in this type of application, if there is a risk of the PRP to enter the blood circulation, must be very careful about the risk of immunological reaction. So the blood group and compatibility between donor and recipient should be used. But my answer here is valid for allogenic PRP. When it comes to autologous PRP, the immunological risk do not exist. The risk is a poor procedure of preparation of the PRP, which may lead to contamination with bacteria. These are risks which can occur. Otherwise, all the application of autologous PRP are showing that it is a product which has a low risk of adverse effect. When it comes to allogenic platelet lysate, so when it comes to being a protein solution, need to make sure that the product is manufactured following good manufacturing practices, subjected to appropriate quality control, and steps are implemented to avoid viral contamination. So in terms of allogenic material, the risk of virus contamination should be taken into account. If it is single donor allogenic platelet material, the risk is statistically quite low because of the measures already in place to screen donor, to test donations, to have traceability. If it is pooled platelet lysate and you multiply the number of donations mixed together, then the risk of viral safety, the viral safety should be taken into consideration.
Okay, thank you, Professor. I see there is two similar question maybe in the chat Zoom, come from my student from Mira Sebayang and Ivel Aprianti. Mira and Ivel ask about how the procedure to make a PRP. I mean, maybe procedure in the laboratorium, how to make a PRP, and what are the problems that occur during the make the PRP, and how to solve the problem when happen in the laboratorium.
Okay. So there are several procedures which can be used in the lab to prepare an equivalent of PRP. Typically, the procedure which is, I think, the most common is to take the whole blood and to collect the whole blood with an anticoagulant. And then to centrifuge this whole blood at, let's say, 300 G, 500 G for 10 to 15 minutes. And this first centrifugation allows to sediment the red blood cell and to have an upper compartment, about 50% of the total volume, which is the plasma and containing the platelet. Then you collect these supernatant and you centrifuge again in order, so at higher G force, in order to pellet the platelet and to have a plasma supernatant. You remove most of the plasma supernatant and then you resuspend the platelet with a residual amount of plasma in order to have a plasma which is 3 to 5-fold enriched in the platelet. So this is the most typical procedure to obtain PRP. Then when you want to do your experiment, you can administer the PRP or do the PRP like this, which means that you expect that the platelet will eventually activate and release their growth factor. Or what you can do is to activate this platelet plasma material with calcium chloride to avoid the effect of the anticoagulant. And therefore, you are going to get a little clot of fibrin. The platelets are going to be activated and release their content in the supernatant, which you can recover after centrifugation. So in this case, you have a pre-activated platelet material which contains the growth factor. So that's one of the issues when you look at application of platelet material like PRP in regenerative medicine. There are variations in the mode of preparation which exist. Just to give you an example, there is another type of PRP where actually the blood is collected without anticoagulant and centrifuged very quickly. And in this situation, you get in your centrifugation tube, actually the blood is activated during the centrifugation. So you get basically two layers, one coagulated red blood cell at the bottom, and you get a supernatant on the surface, on the upper part, which you can squeeze in order to get a fibrin membrane rich in growth factor, which can be used for some application like treatment of leg ulcer, because you can take the membrane, fibrin membrane rich in growth factor, and apply it on the skin, or you can mix or use this membrane for application in for dental surgery implants, for instance. So there are procedures which have been published. And I think the point is to make sure, if you prepare in the lab, is to ensure a good monitoring of the way how you prepare the PRP, and you characterize the product ideally with protein content and some growth factor. Thank you.
Okay, thank you, Professor. I think our time is up. Even there is another question in the YouTube. Yeah, because our time is up. Thank you for your enlightenment presentation. Before we are end our presentation, let's me to resume our material for this morning. Platelet is a small cells, but has many benefits in our life, including healing, regenerative medicine. We can use platelet as a vector for treatment such as neurodisease, Parkinson's, Alzheimer's, that we don't know before. Small but powerful inside our body. Thank you, Professor. Before we are closing this session, I would like to invite Dr. Susi Hartati for taking photo together with Prof. Thierry. Dr. Susi, are you with us?
Welcome.
Okay. I would like to invite Mrs. Maya too for taking photo with us. Mrs. Maya, are you with us? Mrs. Agustina Maya, are you with us?
Yes, yes, I'm here.
Okay. Yeah, we will take a photo together because I worry that Prof. Thierry maybe have another business after this. Okay, Kamita, please take our picture this morning. And Miss Eka, Miss Afrinia Eka Sari as our head of research center. Can you join with us to take a picture, Mrs. Eka?
Yes, yes, please, Mrs. Hati.
Okay. Our committee, please take a picture. I will count 3 before take a picture. Yeah, documentation section already. Yeah. 1, 2, 3. Okay, once again. 1, 2, 3. Okay, thank you, Professor, for your
Thank you. Yeah.
wonderful
Thank you,
presentation,
Professor.
for
Yeah.
your prestigious answer.
And I
very
gave my
glad.
email address in case some students want to contact me. They can send me an email, of course. I would be happy to answer. Thank you
Okay.
for the invitation. It was nice.
Okay,
Thank
thank you for opportunity. Hopefully we'll see you in another agenda next time.
Thank you. Terima
Okay.
kasih.
Terima kasih.
Thank you.
Okay. Ladies and gentlemen, we are going to another speaker in morning session. Yeah. The second speaker is Dr. Susi Hartati, SKPM Kep Spesialis Keperawatan Anak. Yeah, that will present the topic update on health innovation in higher education. Before going to start your presentation, I will read your profile first, Dr. Susi. Dr. Susi had graduated from Doctoral of Educational Management Universitas Negeri Jakarta, Pediatric Nursing Specialist and Magister from University of Indonesia. She is head of Mitra Keluarga School Health Science from 2014 until now. Dr. Susi have various organization experience. There is Indonesian Rector Forum or FRI, APTISI, etc. She had been a trainer for leadership, quality assurance, educational management, and child health. Ladies and gentlemen, please welcome Dr. Susi Hartati.
Thank you, Miss Rohayati, for the times. Can you hear my sound?
Okay, clear.
Okay, clear. Thank you. Bismillahirrahmanirrahim. Good morning, everybody. Good morning, ladies and gentlemen. This section allow me a operation in English and Bahasa. And my presentation is absolutely different in theme from the first speaker. Yeah. There is an update on health innovation in higher education. And the first one, I will present about innovation. What is innovation? Innovation is the term is used great deal in advertising its species and in describing one's company or organization. The term innovation is used much more than actual innovation that take place. Even when organizations are not necessarily doing anything groundbreaking or new, they still call it innovation. Just because it just sounds grander. That is, these are not innovation. Rather, they are simply improvement. Jadi, innovation, kadang-kadang orang itu membuat kata-kata innovation, inovasi, hanya untuk iklan, hanya untuk advertise, bahwa ini kita sudah menyelenggarakan inovasi. Ini kita sudah buat inovasi. Tapi sebenarnya itu bukan inovasi. Itu hanya peningkatan dari sesuatu yang sedikit ada perubahan. Jadi memaknai kata inovasi itu harus dengan hati-hati. Innovation is the implementation of new initiative in order to drive growth, increase revenue, reduce cost, differentiate effect experience, or adjust the value proposition. Ya, jadi bagaimana ini bisa meningkatkan pertumbuhan, meningkatkan revenue, ya, meningkatkan punya pengalaman yang berbeda dan adjust value proposition. Innovation is generally understood as the successful introduction of a new thing or method. Innovation seems to have two subcomponents. First is there is an idea or item which is novel or to particular individual or group. And the second one, there is the change with its result from the adoption or the object of idea. So innovation requires the three major steps: an idea, implementation, and the outcome. The other source, there is in space, they call them innovation divided inspiration, ideation, and implementation. Inspiration is the problem opportunity that brought out the need for a solution. Jadi ada kesempatan masalah ini, bagaimana kita bisa mendapatkan solusinya. It is what motivates the team to innovate. The second one, ideation. Ideation is the process of creating potential solution, developing and testing ideas, and creating prototype to see how this idea might work. Bagaimana ide ini membawa inspirasi ini ke dalam suatu ide-ide, dan bagaimana ide-ide ini diterjemahkan di implementasi. The third one is implementasi. Implementation is bringing the prototype from a project to a product in people's life. If there are inspiration, ideation must be implementation with the prototype. How about the type of innovation? There is a sustaining innovation and disruptive innovation. Sustaining innovation is make it better, bigger, more efficient, and or more beneficial to the end user. Lebih besar, lebih efisien, lebih menguntungkan pada end user, pada pemakainya. Like update model of a car that gets better as mileage, yeah. And the other one, disruptive. Disruptive innovation is significant change, benar-benar berubah. Apa yang terjadi di pandemi ini? Disruptive innovation. It's more affordable and easier to use. How about innovation in higher education? Innovation in higher education illustrates well two general key aspects of the innovation process: doing new things and doing existing things better. Melakukan sesuatu yang baru atau melakukan sesuatu yang lebih baik dari yang sudah ada. Ini yang terjadi di perguruan tinggi, inovasi di perguruan tinggi. Doing new things and doing existing things better. How about the main challenge for higher education driving innovation? Three main challenges: pressure from globalization, changing supply of and demand for higher education, changing its higher education funding. There is three main challenge for innovation. Challenge is innovation in higher education. We have several factors. Yeah, tradition in higher education. How about the tradition in higher education? In order for innovation to take place, there must first be a perceived need for change. Dia harus bisa menerima suatu perubahan. How about the structure? Yeah. Structure organization structure. The structure of traditional college governance on campuses can also create resistance to innovation. Jadi traditional track structure, tidak ada manajemen inovasi, no innovation management. It's difficult to create innovation. Funding is more interest, while more funding is not always the answer to every question. Innovation in higher education cannot be meaningful without change in the funding structure of higher education. Faculty, the faculty is well recognized that without faculty of an institution firmly committed to innovation of a college or university, there is some factor, some stage. If we have innovation in higher education, maybe some individual make opposition. Dia menjadi oposisi, dia tidak mau menerima perubahan. Resisten, tidak mau menerima, menjadi oposisi, melawan, resisten, menolak, bertahan. Kemudian next step, toleration, dia bisa menerima. Akhirnya dia acceptance, bisa menerima dan support, dan akhirnya embrace. How about the institutional level? The first stage is to perception. How about the perception about innovation? Formation of goal, merumuskan tujuan, search. They are search all of innovation, choice of solution, and redefinition of this. There is some challenge to innovation in higher education: accreditation, government, regulation, performance fundings. There is accreditation. There is a blanket in Indonesia for legal accreditation. In Indonesia, there is now have outcome for innovation. All of higher education must have innovation. Government, there is also influence play through politics in higher education as it related to competition, funding, grant, and etc. Regulation and performance funding. There is innovative college and in universities in America, in USA, like a Drexel University, Harvard University of Ann Arbor, Duke University, Northern and Extra, Georgia State University, University of Maryland, Massachusetts University, Institute of Technology, Stanford University, Arizona State STEM, and extra. How about update health innovation, higher education? There is 5 trends shaping for the future digital health in 2022 in Asia Pacific. Rising data volume creates complexity. AI, artificial adoption in healthcare accelerates interoperability solution unlock the power of data. Telehealth delivery move to virtual care models, the rise of Internet of Medical Things, or IoMT. Let me explain the rising data. Just over a decade ago, the world's entire data storage capacity was around 487 exabytes. Wow, wonderful. Semakin banyak data, kita lihat in full data. Bagaimana mengelola data? How to collect data? In 2022, healthcare organizations are searching for ways to integrate and harmonize the data to make meaningful connection that provide actionable insight. Of all industries, the healthcare sector is the leading generator of data, accounting for around 30% of the world data volume. AI adoption. Artificial intelligence is healthcare has largely been a resort to grant-based research to promote innovation in clinical care. In healthcare, AI has potential to make care better, faster, and more accessible for all. And by 2024, McKinsey estimates that more than 50% of technology interaction will be augmented by AI-driven speech, written words, or computer vision algorithms. Kita bisa bayangkan peran AI ini. Bagaimana bisa merubah pelayanan kesehatan. Next, interoperability solution unlock the power of data. Connected, meaningful data is one of the most important tools in digital health toolkit. Having access to rich, real-time, trusted data improve decision-making, operational efficiency, and patient outcome. How to connect data is the big problem. The key succeeding with this initiative is flexibility. It is important to choose a platform that can support the range of interoperability standards. The fourth is telehealth delivered more to virtual care models. The global pandemic, alongside rising consumer expectations, has made telehealth a permanent feature of the global healthcare landscapes. In 2022, we are seeing telehealth move from a mechanism to deliver care outside the hospital to more holistic model of virtual care. Telehealth in Indonesia is growing. Telehealth will move to virtual care models. And the fifth is the rise of Internet of Medical Things, IoMG. The IoMG has the potential to turn from fragmented healthcare system to a connected system of care, powered by real-time patient data. It's amazing. How about connecting the big data to one data, power the real-time patient data, as well as reducing rising costs. It has ability to improve patient outcome, streamline clinical operation, and deliver more personalized care. Ladies and gentlemen, we have the top medical innovation in 2022. The first one is focal biomarkers. They are identifying condition from a conversation. I don't know in Indonesia there is have identifying condition from orphan physician. Dia bisa mengidentifikasi kondisi patient. Number 2 is AI in diagnostic the physician assistant. Artificial intelligence bisa mendiagnosis, can diagnostic the patient. Number 3 is chatbots. Chatbots ini usually we have in Indonesia we have like Hello Doc, yeah, the new first contract point for primary care, Hello Doc, and the Kemenkes ada ya. At home testing kits, we have some lab tests at your doorstep, and the 5th digital health insurance. Too many digital insurance, too many insurance industry move to digital health insurance. How about Indonesia? I have some slide about condition in Indonesia. Bagaimana kita bisa menciptakan policy, ya? If we have make innovation, they are critical area for hilirization from research to end user. There are some factors like a policy, institution, human resource, network, and outcome. The 5 factor is more important for the have innovation. How about the higher education in Indonesia? We have some higher education like LPK ITB, PUU UI, DIIB UGM, dan some more in higher education have management, innovation management in higher education. There is 2020 from 2021 pandemic era. They have 9 innovation from higher education, like Robert Reiser from Institut Teknologi Surabaya, Unair, Robert Kece from UNESA, Universitas Negeri Semarang, ya. iCare, ITS, ventilator portable from ICB, Unpad, GPM, Salman. Genos C19 from UGM, radar pasif, connected, dan sebagainya from ITB, extractotomy from IPB, ONFET 20 from University of Indonesia, swab chamber from Institut Teknologi Telkom Surabaya. There is some product innovation from University of Indonesia in era pandemic is like bilik disinfection, bilik swab test, and geodesic, dengue, yeah. And in University Indonesia, they have the second one is for the health innovation is, and the first one is for technology. Then there is in University Indonesia, there is innovation product like movable hand pusher, high group nasal cannula, Propolis Indonesia. Dan innovation itu bisa menjadi sumber penghambat pendapatan. There is some higher education have some research, some services. Yeah, there is have many money if they have innovation. So the summary is creativity is thinking of new things. Innovation is doing new things. Thank you very much. I
Thank
return
you.
to Ms. Rohayati.
Thank you, Dr. Susi, for your presentation. Ladies and gentlemen, and all participants, now you are your turn to ask the question. You can give the question either in the chat room of Zoom or in YouTube, or you can open your mic for directly asking question to Dr. Susi. I see in the chat room Zoom there is still no question, and I see in the YouTube there is still no question. Actually, maybe while we are waiting for audience question, Dr. Susi, I'm so interesting about your topic about innovation in higher education. Higher education is a spirit, or is it the critical things to make the better society in the next? So innovation will come from the higher education. Maybe could you explain to us how the strategy or how the detailed ways for us as a academic institution or as a student or as a lecturer, how to make the innovation way or innovation situation, maybe in the teaching, learning, or in research in the higher education?
Yeah, thank you, Ms. Rohayati. I explain it in bahasa on bahasa. Okay. Innovation in higher education is more difficult. Yeah, as there is innovation is many departments, and any in teaching, learning, in research, in etc. Yeah, innovation in teaching and learning can be done. Ya, inovasi dalam perguruan, dalam belajar mengajar, banyak sekali inovasi, too many innovation ya, dalam belajar mengajar, dalam belajar research, dalam semua hal kita bisa melakukan inovasi. Tapi apa yang bisa kita lakukan dulu adalah merubah mindset. Change your mindset. Berubah pola pikir kita bahwa jangan di zona nyaman. Don't stay to comfort zone. Don't stay to comfort zone. In comfort zones, we are still comfort. We are still comfort. There's no change. No change. We have to change our minds. We have to make policy. We have to make to change structure in higher education. We have to make funding. That is the problem in higher education, funding. Bagaimana menghargai karya inovasi. Tidak usah menghargai karya inovasi, membuat inovasi, kemudian menghargai inovasi itu. To make innovation is difficult. And many expensive. Performance funding is better. If any innovation, the institution give performance fundings. Institution give performance funding, memberikan kinerja berdasarkan inovasi. That's Ms. Rohayati.
Okay, thank you, Dr. Susi, for your explanation. I see in the monitor there is still no question for you. So I'm really interested about the artificial intelligence, Dr. Susi, especially maybe for teaching and learning in the laboratory practice in our health education. Because as we know that so many health education program and faculty there is have a big course or big credit for practice in laboratorium, and when we have a pandemic situation, is this situation is very difficult for us to adapt, because when we are practice in the laboratorium, we need we need to do directly with the student. Actually, it is impossible when we are going in the pandemic. So how effective artificial intelligence when we are adopt it for laboratory practice in our health education, Dr. Susi?
Okay, thank you, Ms. Rohayati, for your question. There is artificial intelligence for in laboratory or like a virtual laboratory. Yeah? There is needs much money, needs much money. Needs competence of the teacher. Use the artificial intelligence or virtual reality, VR. Yeah. Needs money, needs skill, needs some space, some laboratory, or some equipment. Yeah. There's many interesting, but it's more attention for higher education to make this to build artificial intelligence in laboratory. But for the nurse, for the technology laboratory medis, pharmacy, like the students still reality case in hospital on etc. like in puskesmas dan sebagainya. Still needs reality cases. Still need reality practice, not for just in artificial intelligence in laboratory. Not artificial intelligence laboratory just assist student, assist a lecturer to teach the student, but the students still need reality cases in field like hospital, puskesmas, and extra. Thank you, Ms.
Okay, thank you, Dr. Susi. Ladies and gentlemen, I would like to invite you to directly give the question to Dr. Susi. Please, who want to ask the question? Open
Hello,
mic.
Miss.
Okay, I
Yes.
see.
Yeah,
I
I
hear.
am Nur Andrian Ilsan. Question for Dr. Susi Hartati. So actually that I know it's kind of difficult to our product. I mean, because now we are higher education. So some of the product from the higher education is kind of difficult to go to the, for example, hospital, because we are health education. It's kind of different if we have a product, but we go to the industry like food or drink. It kind of easier than if we go to our product go to the hospital. I don't know, it's kind of gap between them. So I don't know, like speechless. Is what is the factor that that kind of situation, maybe from Dr. Susi Hartati opinion.
Okay, thanks, Mr. Nur, Mr. Rian. Has so many interesting questions. Now, too many higher education have same problem. They have some product, but cannot Hilarization industry in industry. There is menjadi pembicaraan kita semua. There is a many problem in Indonesia. Maybe a policy in industry and policy in government and policy in, I don't know. I have already a presentation about 9 innovation in higher education, but now how? We don't know. The product, where the product now? Where is the product now? I don't know. How about the policy in government? There is some problem. Is many in foreign rector Indonesia. Is this? We are discuss about this. We are discuss about it. How to Hilarization our product in higher education. How to bring our product, our innovation in higher education to industry, to end user, or to some company, some not yet. Maybe 1 or 2 there is, but 9 innovation is stop in higher education. Thank you.
How, Mr. Andrian?
Jadi lebih ke polisi ya Bu ya, banyak.
Policy. Ya ini jadi pembicaraan di Forum Rektor Indonesia juga. Bagaimana hilirisasi daripada hasil inovasi daripada student, hasil inovasi dari dosen-dosen ini bagaimana bisa sampai ke produk. Bagaimana nasib ventilator tadi, bagaimana nasib Ginos, bagaimana nasib itu bagaimana? Itu jadi pembicaraan kita semuanya. Dan ini perlu terobosan. Kita pernah, we have discussed about this problem. Okay, thank you.
Thank you very much, Dr. Susi.
Okay, thank you for the answer, Dr. Susi. Dear audience, is there any question for Dr. Susi? I see in the chat Zoom there is no question, and in the
maybe not interesting.
Yeah, okay. I think our time is enough, Dr. Susi. Before
That's enough. Thank you.
Question, let me to resume your topic. That innovation at higher education level is the spirit to create works, technology, instruments, patents that can support the quality of human life. The application of 3 Dharma of higher education, where education, research, and community services must be in line, allows higher education to innovate more. Innovation can take the form of learning methods, learning technology, appropriate technology that can be used by society and industry. Thank you, Dr. Susi, for sharing your great experience and great material. Hopefully we will meet again in another agenda. Thank you. And
welcome, Ms. Rohayati. Thank you.
Ladies and gentlemen, now we are going to the last speaker in our first session, Mrs. Agustina Mayasari. Mrs. Agustina Maya, SSE APT, will present the topic with title Product Innovation in KUB, Past, Future, and Challenge. Before Mrs. Maya presents her topic, I would like to read her profile first. Okay. Mrs. Agustina Maya had graduated of Pharmacist Profession Program, University of Indonesia and School of Pharmacy, Bandung Institute of Technology. She has so many working experience as Senior Business Development Manager of Kalbe Pharma, Business Development Executive of Kinocare Era Cosmetindo, and Novel Pharmaceutical Laboratories. Mrs. Agustina, do you will share your PPT by yourself
Yes,
or by
yes.
committee?
I will share the slide by myself. Thank you, Ms. Rohayati.
Okay, please welcome Mrs. Agustina. The time is yours.
Thank you. Okay, can you see my screen?
Okay, I see.
Yeah. Okay, I will start my presentation. Okay, good afternoon, everyone. Thank you for having me, and I'm so feel honored that I can share about product innovation in Kalbe. And a brief about Kalbe. Kalbe established in 1966. From the humble start in the garage of our founder, Kalbe has transformed to be the provider of an integrated healthcare solution through 4 business divisions: pharmaceutical or division, consumer health, distribution and logistics, and also nutritional. Being the public company since 1991, Kalbe has been the largest healthcare company in Indonesia and also Southeast Asia, with its extensive portfolio and services distributed nationwide. Kalbe also established footprint in Asia and West Africa countries and consistently built collaborative innovation with prominent multinational companies from around the world. Our vision is to be the best Indonesian global healthcare company driven by innovation, strong brands, and excellent management. And it is our mission to improve health for a better life. Regarding the innovation at Kalbe, the key driver that we keep doing the innovation is due to the global macro situation and also to fulfill our customer demand, and due to also the technology advancement, and also to keep our business sustained for the long term. In Kalbe, we believe that innovation comes from good insight and also creativity. While we still have to keep the balance between the feasibility of the innovation or the project itself, the viability of the business model, and desirability by our customer, and from the integrity point of view, we have to create positive impact for the planet. In Kalbe, we classify our innovation portfolio to 3 horizons. The first horizon is product innovation. It is for the short-term impact that with projects with incremental innovation or improvement of our existing core capabilities. Projects in this horizon usually to serve the existing market with the existing technology or technology that we already own. The result of this horizon will be new product or improved services. The second horizon is business model innovation. This is for the medium-term impact. This is the expansion to new business opportunity. The project in this category will result in new business model or new channel execution, expansion to the new segment of the customer, new market, or new targets. Usually, we employ the emerging technology to serve the emerging market. The third horizon is for long-term impact. This is the project that are disruptive or disruptive innovation, creating new capabilities and new businesses. And this will result in integrated ecosystems or platforms. And we will use the new technology that will be new for us and maybe new for everywhere in the world. And we will also serve new market or new segment of the business. Okay, that's all from the concept of innovation that we perform in Kalbe. And next, I will show some of innovation in our product and services. In specialty category, we have a product insulin that we collaborate with strategic partner from foreign country, and we acquire the technology to do the local production of insulin in our facility. And we also have monoclonal antibodies and biosimilar. This is the biological product that we have collaboration, so we can bring the product to our market sooner. And we also have local development, so soon we will produce this product in our facility too. And the third is medical nutrition category. This is the nutrition product specifically formulated to cater specific need of the patient. In diagnostic category, we also have COVID-19 test. We have real-time PCR test and also LAMP saliva. I will tell about these products further later. And in the preventive category, we have herbal product that will be used in the pandemic situation to strengthen our immune system, and also vitamin and supplements, and also healthy drinks. In digital category, we have 3 platforms. Emos will be the marketplace of pharmaceutical product. Mostran is the digital transportation platform that can manage the end-to-end point of pharmaceutical transportation or supply chain. And Click Doctor is our newly revamped telemedicine platform. Next, I will share some innovation that we did in the past couple of years. The first product is ProofD. The key driver that is the background of the launch of ProofD is the fact that vitamin D is the essential nutrient, but the prevalence of vitamin D deficiency is very high, not only in worldwide, also in Indonesia. It is an interesting fact, since vitamin D actually can be produced by our body with the help of sunlight, by the support of sunlight. And we think that since we live in Indonesia that is abundant in sunlight, we don't need vitamin D supplementation. But the fact is the deficiency rate of vitamin D in Indonesia is very high. And this is also worsened by the lack of awareness of the Indonesian society and also medical society in Indonesia. And certain habits also worsen this condition. So we do the innovation by launching the innovative product of vitamin D with the brand ProofD. This is the first vitamin D product with the treatment dose. And we launched ProofD in innovative dosage form in tablet, chewable tablet, and drops to cater the various needs of our customer. In terms of business model, we employ also innovative business model. We do omnichannel marketing, online to offline, offline to offline, B2B and B2C marketing. And also we build integrated ecosystem to support the acceptance or adoption of vitamin D by our customer. You can see here, this is the ecosystem that we built for ProofD. From risk assessment, we can determine the vitamin D requirement of the people according to their genetic profiles. And also we have e-health and telemedicine platform to do the screening and assess our health condition regarding the vitamin D deficiency. We also have tests for vitamin D level in our body to check whether we have a deficient or sufficient vitamin D level. And we also have complete portfolio for therapy and supporting to treat vitamin D deficiency and also to monitor the vitamin D level in our body. And we hope this ecosystem can solve the vitamin D deficiency problem in Indonesia for a better health of Indonesian society. Okay, that's the story of Proof D. The next is our medical nutrition, NutriCan. NutriCan is launched due to the fact that cancer patient who is undergoing the treatment usually experience eating and nutrition disturbance. This is due to the adverse effect of the treatment itself. Nutrition and also diet plan usually the frequent pain point of the cancer patient and their caregiver, because usually the patient will have heavy vomiting and they can eat properly, and this will worsen their condition since the cancer treatment usually create strong effect to their body. So nutrition is a very critical for the successful of the cancer treatment. So our innovation is we built NutriCan as the first medical nutrition specifically formulated to cater cancer patient needs in collaboration with Darmais Cancer Hospital physician. So the composition has been customized for the cancer patient. And we developed in innovative dosage form in milk drink. It is easy to swallow and to digest. We also deploy the innovative business model, creating omnichannel marketing. And since NutriCan is part of one onco ecosystem, it is the oncology total solution provided by Kalbe to provide end-to-end solution for patient and their caregiver who is undergoing cancer care. So this innovation also categorized as innovation orchestration. You can see that this is the one onco ecosystem. We provide end-to-end modalities to help the cancer patient undergoing their cancer journey. We have complete product portfolio for the treatment and also the services to as the companion diagnostic and also to diagnose the cancer. We have also digital platform oneonco.co.id that will provide everything that information that the patient and the caregiver needs, like a healthcare provider that have cancer care, and also article and education regarding the cancer and the treatment. And we develop also a community to assist the patient and their family, so they can finish and they can focus on the cancer treatment and can achieve the treatment outcome. So this is the ecosystem that we built. We also collaborate with external parties to give more value to cancer care patient and also the family and caregiver. Okay, that's all the story of NutriCan. The next product is Bejo Sujamer. It is the herbal product. The key driver of the launch of Bejo Sujamer is the new emerging trend that jamu is the new espresso. Many millennials and youngsters now see that the traditional herbs is beneficial for them. And we have Bintang 7, our subsidiary, that has been consistently building an ecosystem for sustainable supply chain and development of red ginger, the original herbs of Indonesia. So the innovation that we perform for Bejo Sujamer is we do the innovative process. We accelerate the development process of Bejo Sujamer. In less than 3 months, we launch the product compared to the normal timeline is usually more than 12 months. And we also employ the innovative business model, omnichannel marketing, and developing the Red Ginger ecosystem. This is the ecosystem that we built for Red Ginger. From the community development, we engage with more than 10,000 of the farmers across Indonesia. We provide scholarship for their family or the children for better education. And we also equip the farming tools or equipment so they can, the farmers can do the farming better and with modern methodology. We also cooperate with University of Surabaya and Kyunghee University from South Korea to develop ginseng through tissue culture technology. And we see that this can enrich our herbs portfolio and in Indonesia. From cultivation, we also collaborate with private company to cultivate citronella in Purwakarta, West Java. In terms of extraction method, we do the improvement for the clean production of Red Ginger in collaboration with IPB or Bogor Agricultural Institute and PT SIL. For the scientific evidence, we do the trial supported by the government bodies. So we hope that in the future, not only this ecosystem can provide improved supply chain and better Red Ginger extract, but also other herbal like ginseng and also citronella. In diagnostic categories, in the last 2 years, we impacted by the COVID-19 pandemic. So we developed the diagnostic test to cater the need for huge testing for contact tracing and also surveillance. The background is because the imported COVID-19 test kits were very expensive and limited in supply. And at the beginning of the pandemic, clinical laboratories that can perform the test also very limited. So there's a need to build a COVID-19 testing point everywhere that can do the test fast and accurate. Our innovation is we develop innovative product locally, COVID-19 test kit we produce in our facility, and we develop more convenient testing lamb saliva with comparable sensitivity to real-time PCR test. From the business model, we deploy innovative business model, the expansion of our clinical laboratory, Culgen InnoLab business, to cover COVID-19 testing, and build massive testing point everywhere, like in hospital, clinics, drive-thru, and even home care. We also collaborate internally between Kalbe and entities, Culgen DNA that produce the kit, and Ceval Medica Prima who do the distribution to our outlets, and also Culgen InnoLab who perform the COVID-19 testing. And we collaborate also with external parties like Halodoc, Lovecare, CheckLab.id, Ticket.com, and SehatQ, to name a few. So we can provide the massive COVID-19 testing anytime and everywhere. In digital solution platform, we have ClickDoctor, the telemedicine platform that provides health consultation with doctors and health experts, not only doctors, but also nutritionists and others. And we have a pharmacy platform to supply the medicine and e-commerce for healthcare and wellness products. We also have EMOS, the marketplace for pharmacy, to serve B2B order management platform for healthcare product focused on medical channel or pharmacies. And Mostran is our B2B transportation management platform for specific healthcare product. Okay, there's some of our innovation in various category of our businesses. And next, Our challenges to innovate further will be the recovering economy that will impact the adoption of our innovation by the market. And also we have to overcome the global supply chain issue. This can impact our flexibility and agility in creating new solutions to our customer. But we see that this can also be the growth driver, so we can innovate further to overcome the issue. And also regulatory update like import restriction due to prioritization on local production, the digital transformation by Indonesia healthcare system, and also halal certification. This is factors that we need to see carefully and use it as opportunity to innovate further in the future. So speaking of the future innovation, we will talk about these 6 aspects. It is the healthcare access, how we improve the access for healthcare for everyone. So we will strengthen our contribution in catalog or national health insurance program. Second is the advancement in biotechnology, immuno-oncology, and also genomics. We see that there are growing pipeline for biotechnology, immuno-oncology, genomics, and also nanomedicine, mRNA vaccines and therapies. Next, will also the digital transformation and its impact to the disease management. We see promising development in digital medicine, digital therapeutic, and digital companion. We also interested to see further the impact of metaverse in healthcare, virtual care, artificial intelligence, and big data utilization for drug discovery and strategic disease management in the future. Mental health and well-being also something that we need to carefully monitor, because they are shifting from disease care to prevention and well-being, and this will drive higher consumption for consumer health and nutrition products. And public health remodeling, the digitalization of public health services, we will see that new landscape in public health in Indonesia. And also speaking about ESG or environmental, social, and governance, we see that in the future we have built the smart factory and green manufacturing. So I just share here the top 10 healthcare trends in innovation. We see that the prioritized in artificial intelligence, Internet of Medical Things, how everything will be connected in the future, and also telemedicine, the adoption will be much higher in the future, and big data and analytic, immersive technology, mobile health, everything happen in our mobile health now. We have special relationship with our smartphone now, and also 3D printing, blockchain, cloud computing, and also genomics. I think that's all from me. If there's any question, I will be happy to answer. Thank you.
Thank you, Mrs. Agustina. So wonderful experience and sharing. I hope all participants got the idea from your presentation. Ladies and gentlemen, I will open the discussion session. Please, for all of you who have a question, can ask Mrs. Agustina Maya directly. You can open mic and share the question to speaker.
Thank you, Mrs. Ati.
Okay.
Hello, Mrs. Agustina. Nice to meet you.
Nice to meet you, Ms. Afrinia.
To us, you can attend this conference and sharing about the product development in Kalbe. I want to ask you about the opportunity that maybe we have to work together Calbe with university, because there are many product innovation that has been made by university. And the second question is how the procedure, or how to get maybe some scholarship, or what funding to create the product innovation to our university. Thank you very much.
Thank you.
I'm so sorry, my question is so frontal. Yeah.
That's okay. Miss Afrinia.
Okay, you can answer directly, Mrs. Agustina.
Yeah. Opportunity for research or collaboration with university is very wide open, and we are happy to collaborate because we can do everything by our own, and we also have experience for ABGC collaboration. So if from Stikers Mitra Keluarga already have the proposal for the research, you can just submit. Maybe you can submit it to me, and I will deliver it to the responsible person or the person in charge for that area. And regarding the scholarship, we also have experience. So I will invite to also submit the application. Maybe I will facilitate, and I will deliver the application to our foundation that already do the funding for scholarship in medical or scientific background. So it is really possible, and just contact me for further information. I'll be happy to facilitate.
Thank you very much, Mrs. Agustina.
Thank you.
Okay, that's the good news and good change for us, maybe. Yeah, especially maybe for pharmacist program, maybe for nutrition program. Yeah. Okay, thank you, Mrs. Eka and Mrs. Agustina. We are continuing to the next question. I see there is a question in the YouTube chat room, Mrs. Agustina from
Me. I want to ask.
There is participant
Yes.
who will ask a
Raise
question.
hand.
Okay. The first, Panoon.
Yes.
Please,
Thank you very
Pak
much,
Nur.
Miss Rohayati. Also, thank you very much for Miss Agustina join our conference. Nice presentation. And actually, I am from medical laboratory technology, and now we develop. One of them is kit for detection bacteria. And
okay.
Yeah, actually this conference is quite well arranged. I mean, for the first speaker is the researcher, the second is educational expert, and the third is product. I mean, company. And
Yeah.
like we asked, like my question in the second speakers, it's kind of difficult if we have a product and then the product go to the hospital. It's kind of difficult that because I saw in your PPT, your product is like food or jamu. You collaborate with the university like Universitas Surabaya or IPB dan teman-temannya. But if your kit, PCR kit, you are not collaborate with university. Maybe you have your own development staff
Team.
team.
Yes.
And so that's why, like, if we are like educational institution, we have a product, like we want to go to the hospital, what is your suggestion? I mean, is it difficult or is it impossible? Or like, what is like in your opinion as a company, Calbe Pharma, like, yeah, maybe you can give us suggestion actually for our department, like medical laboratory technology, that want to create the product and go to the hospital. I don't know, it's kind of obstacle. And the second one, do you have the product that you adopt from the outside of the country, abroad.
Yeah. From
Like
partner.
because we know that some of the company, pharmacy company in Indonesia, they adopt from China and then they buy the patent and then they just apply in Indonesia, and it's have one brand, a good brand until now. So what is your question for the Kalbe Pharma? Thank you very much, Miss.
Okay, thank you. I will answer the first question first regarding the commercialization of bacteria detection kit that you developed. Is it developed by Stikes Mitra Keluarga?
Yes, but still in the basic
scale.
way. Yes.
Okay. Okay, my opinion is maybe you need to benchmark with our subsidiary that produce the laboratory kit, because to do the commercialization, you need to meet the several standard, like you have to be registered to the MOH. So the product should be can be produced in a certain standard, in the standard that has been approved by our government. And also you have to have the economic of scale to serve the demand of the customer, because the continuity of the supply will also be considered by the hospital or your customer. So I think because it's still in the development, it is very good if you get familiar with the regulation aspect and also the commercial part of the production and also the market. And I think it is very possible if you can do the like a benchmark visit to the Kalbe subsidiary that do the business. So you will know about what is required to launch the product, and you can also adjust the the product development process to meet the standard. And the second question is you asked about the technology transfer or the patent transfer from our strategic partner. So usually we do the collaboration with the foreign company, because usually they have advantages to us compared to if we do the development by ourselves. Like usually they already have the data for registration, because drug and biological product registration require extensive documentation and scientific evidence to prove the safety and efficacy. So that's it is, I think the competency in Indonesia is still developing. That's why we collaborate with foreign company, and it will depends on the collaboration and the market potential itself. Usually the partner will see the opportunity for them to expand their business further in Indonesia to do the technology transfer. So we can do the local manufacturing in our facility, and it will require some of business deal with the partner first. I hope I answer your question, or maybe
Yes. Thank you very much. Very clear.
Thank you. Thank you.
Okay, thank you, Mrs. Agustina. I see there is a question in the YouTube chat come from Mrs. Melania Perwitasari. Mrs. Melania asked you about how education institution can collaborate with pharmaceutical industry, such like Kalbe, maybe to make innovation product together.
Yeah, okay, maybe it is the same with the first question from Ms. Aprinia. Actually, the opportunity for the collaboration is open wide. All you have to do just submit your proposal of research, and we will review it carefully. And if it's in line with our business direction and what we do right now, I think it is very good for us to collaborate, because Kalbe cannot do everything by our own.
Okay, thank you. And in the chat Zoom, I see there's a question from Dito Anurogo, TMU Taiwan. Dito ask you about what are the obstacles, challenges, and pitfalls in implementing top 10 healthcare trends and innovation in 2022 to society. How about the regulatory and policy of government?
Okay, thank you, Mr. Dito. Yeah, for the question. Obstacles, challenges will be, of course, to change the mindset, like Dr. Susti mentioned earlier, because as good as we want to change our situation and our life, actually we don't like changes. We don't like something new. We wonder, is it really good or only for short term? So the challenges will be to change the mindset of us at the first, and also our target customer and our user. Usually they will digital technology adoption. Some people will have difficulties in understanding about the technology and the benefit for themselves, and also they need also to learning curve to get familiar with the technology, and they will have some what we call it, wondering or afraid of that the digital technology will replace them in the future. Like a digital consultation, some of the doctor will resistant for the technology in the past. Some doctors said that teleconsultation is not sufficient to do the diagnostic, because in their medicine education, they have to meet the patient to evaluate the patient condition directly and build the diagnosis. But due to the pandemic, we show that the teleconsultation has its place in the healthcare because of the restriction to go to the hospital. So I think all we need to do to overcome the obstacles is just keep doing it, and we have to be flexible with the market situation, with the mindset of our customer, and also the rules that revolves to the healthcare practice in Indonesia. And this will bring to the second question about the regulation and policy of our government. Previously teleconsultation is also not accepted by our government to do as the proper healthcare practice in Indonesia. But we see that due to the pandemic, actually we understand that we need to accept the benefit of this digital consultation with some note that if the condition is serious they still need to go to the hospital. But actually, in the end, that the teleconsultation has been accepted widely in Indonesia now. So I think the regulation and policy will always be late compared to the advancement of the technology. But if the condition is required or the technology to be implemented, our government will change or modify the regulation to allow the the innovation to be implemented and solve our problem. So I think what we need to do is change our mindset and just keep doing what we're doing as long as what we do is give added value to our customer and society. Remember the innovation sweet spot that I mentioned in my presentation, the viability, feasibility, and also desirability and integrity of our innovation. And the rest will just follow. I hope this answer your question.
Okay, thank you, Mrs. Agustina. Mr. Vito, are you got the answer? Is Mr. Vito still here? Okay. The next question, Mrs. Agustina, come from Abu Mosadek. Abu Mosadek ask you about, please tell regarding BA studies to ensure quality and efficacy of medicine produced in your country.
Okay, thank you. Actually, BE studies usually just to show the comparability of the product to the one that has been approved by our government to ensure the quality. But for the efficacy, usually if it's a new treatment, you need to furnish the product with good scientific documentation, means the clinical study. For BE study, actually, it is commonly performed in Indonesia. We also have our own subsidiary that do the BE study. So if you have the product that need BE study to be performed, you can just contact us. Yeah, thank you. Is it answer your question, Mr. Abu? Okay, thanks.
Okay, we are continuing to the next question. Maybe because your topic is very interesting, Mrs. Agustina, there is so many questions in the YouTube chat, and here is in the chat Zoom. From the YouTube, I see there is a question from Mr. Reza Anindita. Mr. Reza asked two questions for you. The first question is, it was seen that there was a monoclonal antibody product or MAB. What is it and for what treatment? And the second question, in the development of herbal products, at least to what stage, if it is developed at the educational level, such like universities, so that freshly graduated students can work at Kalbe? That's all question for you.
Okay. If I forget, can you repeat the question? But at the first, it's the monoclonal antibodies. We have portfolio for oncology or cancer care. We have several agents in our portfolio, and it is have their own specific indication for each monoclonal antibody that we have. And the second question is on herbal stage of development. Is it right?
Yeah.
Okay. It is in commercial stage. We like I present Before that, we already commercialized the product, but we collaborate with the farmers that produce the plants, the red ginger, citronella, and also ginseng. It is in development, and they do the cultivation and extraction, and we formulate it into the finished product, and we do the commercialization. I think that's a question regarding the fresh graduate to contribute or something.
Yeah, is there a change for fresh graduate to work at Kalbe?
Oh, sure, of
Maybe.
course. Just send your application to Kalbe.
Okay. Okay, thank you, Mrs. Agustina. Maybe the last question come from Mrs. Intan Fidelia. Mrs. Intan ask you about, can you explain more about business model innovation that Kalbe has been conducted?
Okay. Actually, business model innovation is related closely with our current operation. So we have for division, like I mentioned before, pharmaceutical, consumer, and nutrition, and distribution and logistics. So each division has their own operation and cater specific target of customer. And they have their own like business as usual, like we produce the product, we distribute it from through our distributor or the distribution division, and we deliver the product mainly for pharma business. We do B2B marketing, and for the consumer health, they do the B2C marketing. So if we do innovation in business model, we kind of mix of our operation. So the team that previously only do the B2B marketing, they will also cater the B2C marketing. Like if for pharma team, our customer actually is the doctor and hospital, clinics, and pharmacies. And if we do the business model, new business model or business model innovation, we also will do the marketing activity through the consumer channel, like we do the direct to customer education and webinars to the public. It's like something like that. And also it's the regarding the online to offline, because in previously our activity mainly offline, but due to the recent development, we have to also pay attention to our presence in online channel too. So we kind of mix of the online activity with offline activity. I hope this answer your question.
Okay, I hope the question from Mrs. Intan can answer. Okay, that's all the question for you, Mrs. Agustina. Such
Thank
wonderful
you.
presentation and topic and experience. So audience very curiosity for your topic. Before I close the session, let me to resume your topic that innovation in Kalbe Pharma have 3 steps of portfolio. The first is product innovation, then business model innovation, and innovation orchestrator. And Kalbe collaborates with all farmers, researchers, university, and all aspects for produce innovation product for a healthy society. Yeah, ladies and gentlemen, now we are going to the end of session 1 before we are closing the session. Yeah, I would like to say thank you for all of the speakers, for Prof. Tiara, Dr. Susi, and Mrs. Agustina Maya. And thank you very much for all committee who are having me in this wonderful opportunity. I hope we will see in the next agenda soon. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. I will give back the session to the Master of Ceremony. Thank you.
Thank you, Mrs. Rohayati, for moderating sessions with the Honorable Speaker. Excellencies, participants, ladies and gentlemen, we will have a break for prayer and lunch until 1 p.m. and follow it with the second session. After lunch, we will continue with the second session. The first speaker in second session is from Division of Family Healthcare Nursing, graduate from School of Health Sciences, Kobe University, Professor Naohiro Hawashi. The second speaker is Professor Sirichai Adisakwatana from Department of Nutrition and Dietetics, Faculty of Allied Health Sciences, Chulalongkorn University. The third speaker is from Badan Riset dan Inovasi Nasional, Dr. Ishelianti, MSc, and the last speaker, Professor Abushir M.D. Mosadi from Department of Pharmacology, Utara Denik Medical College of Bangladesh, and will be followed with discussion sessions. And please be kind to joining with us again after break. For your information, link of attendance will be shared at the end of today's program. Thank you very much. Other than that, we will present the video of the second winner placed in the Institut Pertanian Bogor with the title Tari Enggang Gading from S. Kalimantan, Indonesia. Please enjoy. Ladies and gentlemen, conference is going to begin in 5 minutes. Please be prepared. We would like to say thank you again for the support of our sponsor, Rumah Sakit Mitra Keluarga Group, to the Second International Lab Health Student Conference 2022. For all participants, please turn on your camera. Excellencies, participants, ladies and gentlemen, we are now continuing our meeting to the next agenda, that is the second panel sessions. This afternoon sessions will be moderated by Mr. Nur Adian Ihsan, PhD. Ladies and gentlemen, please welcome Mr. Nur Andrian Ihsan.
Thank you very much, Master of Ceremony Miyuki Esther. Our Honorable also Dr. Susi Hartati as SKP MKep Spesialis Keperawatan Anak as our head of Stikes Mitra Keluarga. Okay, now we are going to the second session after our lunch break. And if we see our rundown, we have 4 speakers. The first is Professor Naohairo Hohasi from Division of Family Health Care Nursing, Graduate School of Health Sciences, Kobe University. And so thank you for coming, Professor Naohairo Hohasi.
Thank you. I'm now on the business trip and I'm in the near the sea. So can you hear me clearly?
Yes.
Okay,
Sure.
I will start the lecture now. Okay.
Yes, because I know Professor is in the trip, so it's kind of
Okay.
busy. And thank you for coming. And
Thank
the
you so much.
second speaker is Professor Sirichai Adisakwatana from Department of Nutrition and Dietetics, Faculty of Allied Health Sciences, Chulalongkorn University, Thailand. And then the third one is Dr. Is Helianti, MSc, from Badan Riset dan Inovasi Nasional, Indonesia. And then the last one, Professor Abu Shed Musadek from Department of Pharmacology, Uttara Adyanik Medical College, Bangladesh. And for the first speaker, it will going for 30 minutes speech. After that, 15 minutes for Q&A session. So I will read the CV of Professor Naohairo Hohasi that already joined with us. Yeah, if we see the CV, Naohairo Hohasi, PhD, RN, PHN, LSN, and AHFAAN. Dr. Naohairo Hohasi graduated from the Faculty of Medicine, the University of Tokyo in 1989. He withdrew from the Graduate School of Medicine. The University of Tokyo is a tough university, is a #1 that I know in Japan, in 1993 and obtained a PhD from the same university in 1995. So all of the studies be held in Tokyo University. While in graduate school, he was engaged in research and oncogenes, but upon graduating, he decided to move to the world of nursing. when the Department of Family Nursing, the University of Tokyo was initiated. He was named among his international activities. He has served as a member of the board of directors of the International Family Nursing Association. So he is also the board director in the International Family Nursing Association. So if we can see so many journals that already as an editor for him, and also he also been involved in the authorship and publication of over 100 works, including new family health care nursing, theory, practice, and research. Actually, I cannot read one by one because it's so many experiences. So now, for Professor Naohiro Hohashi, the time is yours.
Thank you for your introduction. Hello, everyone. I am Naohiro Hohashi at Kobe University. I'm a professor and I major in the family healthcare nursing. So I will talk about the family healthcare nursing during the coronavirus pandemic. So I will share my slides now. So today's title is Theory-Based Family Nursing During the Coronavirus Pandemic. I have no financial conflicts of interest disclosed concerning the study. First, I'd like to explain the definition of family healthcare nursing. The family healthcare nursing is defined as within the nursing professional as a nucleus, the practical science of independently and autonomously maintaining and improving family functioning by the family, and preventive and therapeutic support to deal with family signs and symptoms to help enabling self-actualization of the family. What is the meaning of therapy? It embraces therapy and treatment and can be used in physiotherapy, occupational therapy, music therapy, and others. So I want to use the therapy in the family healthcare nursing. This explains the family nursing theory. The theory means a consistent concept, definition, proposition for describing family phenomena and providing explanations to make possible predictions and control and present a systematic perspective. In the theory, I think the most important aspect is can make predictions and control of the family. So I will explain how to intervene to the family afterwards. According to the breadth of applicable family phenomena, it divided into three. One is a ground theory, and middle range theory, and practice theory. This explains practice and theory. The practice and theory of family support can be likened to a suspension bridge. This is a suspension bridge. The bridge's pillars is evidence, and the cables that suspend the bridge is the theory, and the path on which people cross over the bridge is practice. So the pillar is evidence, and the cable is the theory. And after that, there is a practice. To realize this practice of high-level support for families, it is essential for it to be backed up by family nursing theory and experience. This website shows my family consultation unit. It has been said, without theory, there can be no practice. And without practice, there can be no theory. So fusion of theory and practice is very important. The key is to realize a combination of understand theory and be capable. That is a practice. As family nursing theory from Japan, I proposed 3 major theories for family healthcare nursing. These are concentric sphere family environment theory, that is CSFET, and family care caring theory, that is FC2T, and family belief system theory, FBST. One is CSFET, and FC2T, and FBST. These are 3 major theories in family healthcare nursing. This is the original paper to develop CSFET. The CSFET is middle range family nursing theory proposed by me 2005 that focuses on the family environment that acts on family well-being by taking up the family system unit from the chrono and spatial axis and aiming for holistic, high-level, high family existence. One characteristic of CSFET is that its development was based not only empirical knowledge, but through results of scientific research. So this is a modern theory. So CSFET is developed by research. I conducted research in USA, in China, in the Philippines, and also in the Indonesia. I visited Riau province. I explained the development of my theory. Target family includes those in Japan in a wide variety of geographic areas, major cities, rural areas, offshore islands. Now I'm in the offshore islands. This island is very small and mountainous districts, as well as a family in a variety of countries and regions, Canada, China, Indonesia, the Philippines, and the United States. This resulted in the creation of global theory because I conducted research all over the world, which was developed based on multi-method research, such as family interviews meetings subject to over 1,005 families, family ethnography, and a total of over 90,000 paper questionnaire surveys. Through development of research and synergistic clinical applications, evidence creation and improvement underwent repeated development. The family transact with the family environment, which expands externally and internally in a dynamic process. Family resources, family functioning, and family signs and symptoms can be regulated. CSFET is a graph that maps out the CSFET. CSFEM. This is a model, and this is a theory. In my theory, model is a graph of the theory. So this is a model of my theory. The family environment forms 3-dimensional chronospace along 3 assessment axes. This is the structural distance and functional distance and temporal distance, in which 5 systems. This is a supra system, and macro system, micro system, and family internal environment system, and the cron system. 5 systems are positioned, which this shows the detail of the CSFEM. What is the structural distance? Structural distance is physical, objective, from the physical and objective perspective, the level of physical objective separation from the family. And functional distance, this is the condition of family environment from the psychological, subjective perspective, and the level of psychological subject separation from the family. And temporal distance. This is a transformation or process of family and family environment from the chronological time. Chronological means the time perspective and the duration of separation between the particular moment and present. In the CSFET, beliefs and beliefs of family members included in the functional indicators as an item, which the function acting as a family well-being. In total, there are 42 functional items. So you can see 42 or 43 religion, national and religious characteristics, language, and so on. There is 42 or 43 assessment items. The entirety of family system unit is established, and by adaptation of the family to the family environment, the family well-being can be realized. In my theory, I already developed assessment model and intervention model. Assessment model is called family environment assessment model, and the intervention model is called family environment caring model. So I will skip to the next slides. This shows the family environment assessment model. This composed of family observation and interview and measurement test. Family observation and interviews is a qualitative assessment, and measurement test means a quantitative assessment. So we did the family assessment qualitatively and quantitatively, and we can get the full image of the family. So this shows the assessment model in more detail. This is qualitative and this is a quantitative. And this slide explain about the assessment model. So as I explained, qualitative assessments from the qualitative assessment and the quantitative assessments, we can conduct the assessment on the as a family as a whole. Is it okay? And one characteristic of the FEAM assessment model is that it can be used to conduct family assessment through mixed methods that combines qualitative and quantitative. This explains the family observation and interview. There are many assessment tools. So this name is here. So this is one of the tools. The name is Chronological Table of Plot of Family Story, PFS. PFS is a chronological table indicating the relationship and the process of the plot of family story, family drama, family, this is a plot of family story, and drama and story, degree of family events, condition of changes in the family. So this is a tool. We ask to the families about the history of the family, and we write down the history here, and we can assess the chronological history of the family. So measurement test is a quantitative assessment. By multiple measurement tests, the primary objectives are assessment of the degree of family functioning and the needs of family support. There are many tools for measurement tests. The name is here. So I will explain one tool. The survey of family environment is self-administered family functioning family demand survey that examines the degree of family functioning. And this tool has been translated into 6 languages. This is English and Indonesian, and also Chinese and Japanese, and in Tagalog, Philippine language. This slide shows the intervention model. Family environment care caring model is a family intervention model using the yardstick of the CSFET. This intervention model describes the desirable family phenomena for the family system unit and nursing professional, and through holding of joint family meetings, intentionally and systematically implements family caring intervention for the family. Next, this slide shows the impact as applied to the CSFET. In the CSFET, impact is defined as the results of the action of one thing upon another. Impact has directions, which can be classified into positive, negative, and text sensitive. These impacts can be classified into impact on family external, family internal, family chrono, environment, and family. And such impacts on the family can be comprehensively clarified. Impacts of the coronavirus pandemic on families. Positive impact. First, positive impact. Increased closeness of parents-child relationship, deepening family ties, and so on. Next, negative impact. For example, deterioration in children's physiological well-being and parental anxieties concerning their children, and so on. Next, context-sensitive impact. For example, a temporary closure of educational institutions, increased family time together. So I will explain the impacts in detail. The COVID-19 pandemic has impacted positively in the family members spend time more together, resulting from parents telecommuting from home and children's absence from school, which in turn increased communications within the family. This is a positive impact. On the other hand, the pandemic also impacted negatively in that it increased stress due to prolonged contact between parents and the family, parents and children in the family. And next, I will explain the primary impact and the secondary impact. The primary impact of telecommuting and the absence of children from school were accompanied by a secondary impact of family stress caused by interaction between family members, which are referred to in general as impact. So the primary impact caused secondary impact. The impact is total of primary impact and secondary impact. So I will explain in the CBAN disaster. CBAN disaster is an acronym for chemical, biological, radiological, nuclear, and explosive disaster. COVID-19 is categorized as biological in global crisis situation. I will explain about the coronavirus, COVID. This is short. This coronavirus is shortened COVID-19. The coronavirus, which is divorce triggered by the corona troubles, has been observed since the declaration of COVID-19 pandemic, which come about mostly as a result of voluntary curfews and teleworking. The reasons for corona divorce include stress from constantly being together, differences in awareness of the COVID-19 crisis, differences in hygiene concepts, stress due to differences in carrying out household chores, and anxieties brought on by decreased incomes. In order to avoid corona divorce, it is important for couples to make time to communicate and to develop appropriate physical and psychological distance between them. Lastly, I will explain my family nursing consultation unit. In 2017, CSFET-based family nurse consultation service was opened as Japan's first family nursing clinic. It offers local resident free consultations to resolve family problems. It is operated using social media, WeChat, and video conference software, Zooms, and so on. This is a flyer for this unit. What is the CSFT-based family nurse consultation unit? This unit provides a high-level support to families based on the CSFET theory, Nursing professions guided by the CSFET, together with family, utilize a variety of tools to work together, resolving family problems or difficulties that cause distress in families, thereby promoting family happiness and family functioning. This is a process of consultation: appointment, initial meeting, clarification of family problems, and creation of family assistance plans. And after that, follow-up meetings. This is the process of the consultation. So the clients is people age of 18 and above. It opens weekdays and Saturdays. Location, about how concerning the location, conducted at my university, and as I explained, conducted remotely. So during the coronavirus pandemic, the remote consultation is very important. Types of consultation is here. The time is up.
Yes, Prof. Maybe like 2 minutes.
Okay, I see. This explains the virtual family consultation. For the virtual family interviews meeting to the effectively utilized an intermediate or advanced level of IT literacy is needed. So this is a reference. This is a development paper of the CSFET, and this is the development paper of the intervention model. So this is my contact information. Please send email or visit my website. Thank you so much.
Thank you very much, Professor Naohiro, for your very nice presentation about family nursing. Also, you create the theory, also the concept. It's very nice about family nursing. So now I am opening the Q&A session. If you have any question, so just ask. But for the priority, maybe for us directly. If there is no question for asking directly, so you can text in the chat box. In bahasa also okay. Pertanyaan nggak? Nggak apa-apa. Oh yes, we have Mrs. Ati Rohayati that will ask.
Thank
Okay?
you,
Yes.
Mr. Noor.
Yes.
Thank you, Mr. Noor, and thank you, Prof. Naohiro, for your good presentation. Actually, I'm interested in family nursing in my university. So I wonder to know how is family nursing practice going on in your country before and in pandemic era? That's the first question. And the second question is, how was family nursing impact in reaching indicator government program, such like maybe hypertension, or in my country, such like stunting or another government program? And the last question is, I'm really interested in family nursing consultation unit. Is there
Oh, sound is not good.
Yeah, I guess it's stuck. Maybe Professor Naohiro, you can answer 2 questions first.
Okay, I cannot hear clearly. So the first question is before 2000 area? You ask the history of the family nursing in Japan?
Yes, I mean how the family nursing practice going on or practical in your country before pandemic, before COVID-19 pandemic, and along when the COVID-19 pandemic happened.
Okay, I see. So in Japan, the family nursing starts at the 1990s. 1990. So we have already 30 years history of the family nursing. And so the government established the Department of Family Nursing in the Tokyo University in 1993. After that, we started the research and practice of the family nursing. Now we have trained the clinical nurse specialist, not generalist. At the graduate school, we provide education for the generalist to be a specialist. So the in the hospital, some clinical nurse specialist in family nursing is working, but the number is not so large. But in Japan, as in your country, the people put a high value on the families. So the family is very important for the people in Japan as in your country. So before, after COVID-19 pandemic, the family nursing becomes more important. So we tried to provide virtual online support to the families. So in Japan, online support, virtual support is not so developed. But after coronavirus pandemic, the virtual consultation becomes more important. Is it okay for you?
Okay, I got it, Professor.
And your next second question is, I cannot hear clearly. So can you explain one more?
Okay, this is about the impact of family nursing practice maybe to help the government reach their indicator program, such like maybe for decrease hypertension in the people or maybe for decrease stunting in the people. Is there any high effectiveness by practicing family nursing to reduce the indicator of health in community or in the society?
Oh, I see. So the family is in the community. So the most important field to conduct family nursing is community, not in hospital. Because in hospital, there is no family, only the patient. But as you mentioned, the patient with hypertension, he or she becomes hypertension because of a high level of high level taking salt. So the daily food I don't know how to say. Daily food is important to improve the hypertension. So the we provide education not only to the patient but also to the family members. So in many situations, we need to provide education not only to the patient, but also to the families. So we call the family to the hospital, and we provide care to the family. But primarily, we need to provide care to the family in the community. So in your country, Poshandu is very important, very good system. But in Japan, there is no system like that. So I hope the system like Poshandu is needed in Japan. Is it okay?
Okay, thank you, Professor. Maybe the last one, how you conduct or how you build the family nursing consultation unit in the university. Is that under government program?
Pardon, my family nursing unit is?
Yeah, how would you develop family nursing consultation unit? Such like your present last about family nursing consultation unit, is there under one university such like Kobe University or is it under the government program?
In Japan, we cannot open a clinic. So this clinic is based on the research. So we deliver many flyers to the communities, and we open a website about my clinic. So the family in the communities come to the university, my university, and we provide care to the families. This system is unique to our university. So this is only one consultation unit, family consultation unit in Japan. So we, university teachers, provide care to the families. But this is based on the research because we cannot open clinic in Japan. Nurse cannot open clinic in Japan. It's okay?
Okay, thank you for all your answer, Professor. Such a wonderful topic and experience. Thank you.
Thank you so much. Please send an email to me.
Okay.
Thank you very much, Mrs. Rohayati, for the question. Is there any question directly from the participants to make discussion flow better? So I invite for any participant want to ask directly. If no, so I will read the chat box. There is one question. Such a wonderful presentation and important topic, Prof. Since family issue is our all concerns, I am Guntari. Could you please explain more how to let people have the understanding of the limitation of virtual family meeting compared to the actual family meeting, so that the goals for the solution still can be achieved? Thank you, Professor. So you also can read directly in the chat box.
So the goals for the solution still can be achieved. Okay, I see. So for example, if we go to the house, we can see how they live in the house. So the virtual meeting, in the virtual meeting, we cannot see how they live in the house. It is the most big problem. And also we cannot see or understand the communication style between families. So we have many limitations in conducting virtual family interviews or meetings. But as I explained here, so we get more advanced level of IT literacy, the more efficiently we can conduct family interviews or meetings. So we are not familiar with virtual family interview meetings. But if this becomes more widely used, so the problem will be solved. Is it okay?
Yes, okay, Professor. Thank you very much.
Okay, thank you so much.
Okay, now we continue to another question. Somebody wanna ask? Yep. Okay, Anissa Noviana Herlambang, raise hand. So please, if you want to ask.
Okay. The presentation was very interesting, so I want to ask you, my question is, so far, what is the biggest cause of divorce during the pandemic of COVID-19, maybe in Japan or in the world? And then is there a continuation of the system? That's it.
Yes, Professor.
You mentioned if the situation continues.
May I repeat? Okay. So far, what is the biggest cause of divorce during the pandemic of COVID-19? And is there any continuation of the system?
This continuation of this system.
Okay. Yes.
Your question is the continuation of the system. Oh, I cannot clearly understand the question. Can you explain more?
So maybe I will help. So it's like because you have a system for like observe the divorce in coronavirus pandemic. So is there any like continuation itu? Oh. Yes, the sustainable step in your system.
Okay, I
from
see.
the case, divorce case.
Oh, I see. I started virtual family interview meetings about 5 years ago. So the virtual or online system started before coronavirus pandemic. And I did the research using Zoom. For 24 hours. So because we connect to the family by using Zooms, and I put many camera in the house, and we can observe their living, and I can provide consultation to the families. So this system started before coronavirus pandemic. So the system will be continue after coronavirus pandemic, and the system must be polished up, must be improved. Okay.
Is that clear, Anissa?
Okay, thank you, Professor.
Okay, thank you very much. Actually, yeah, because the topic is quite interesting. So about family nursing. So I will resum the topics. Family healthcare nursing, a consistent concept, possible prediction and control, present systematic perspective. That interesting is you create the concept, the theory about the three major concepts: family environment, it's including middle range family nursing theory. The second one is caring theory. The third one is belief system theory. So it's quite interesting. Also, corona divorce, yeah, is the short term that interesting also because also many cases also in Indonesia like divorce or stop to study after pandemic. So it's kind of difficult. And okay, because also the time is up. So after this, because we want to have a photo session together with another speakers in one frame. So I will invite another speakers. Dr. Is Helianti, MSc. Are you there? So Professor Sirichai from Thailand. Sirichai Adesakwatana, are you there?
Yes, I'm here.
Okay. Oh, thank you. But Professor Nauhairo is off cam. And Dr. Susi Hartati, as our head of Stikes Mitra Keluarga, maybe we can take a picture together. Yeah, because Dr. Susi said to me, have a meeting. So maybe maybe the representative, Mrs. Lina Heridapinem and Mrs. Lisbeth Pardede, maybe you can join. Also, and Miss Rohayati.
Okay, thank you.
Can join with us for documentation.
Okay.
Okay. Ready? Okay, ready? Mr. Rohayati? Okay. 1, 2, 3, cheese. Okay, thank you very much, Professor Naiharo Hohasi, for your joining. So enjoy your trip. I
Okay,
guess,
thanks so
yes,
much.
yes, thank you for.
Sorry, Pak Rian.
Tahan. Okay, Dr. Susi Hardati is joining us now, so we can taking photo together. Professor Naiharo, please. I'm sorry. Yes.
Okay, see.
Yes, for our documentation. Okay, 1, 2, 3. Cheese. Done. Thank you very much, Professor Naiharo Hohasi.
Thanks so much. Terima
Hope
kasih.
you can come to Indonesia again instead
yes.
of Riau. Yeah, you need to visit Jakarta or Bekasi.
Okay, thanks so much.
Okay, thank you very much, Professor. Okay, now, yes, after a great discussion with Professor Naiharo Hohasi in the nursing department, so we can continue to nutrition department. That is Professor Sirichai Adisakwatana is already joined. Thank you very much. From Department of Nutrition and Dietetics, Faculty of Allied Health Sciences, Chulalongkorn University, entitled Butterfly Pea Flower. In Indonesia, it's like bunga telang, a potent source of bioactive anthocyanin-rich diet. Okay, I will read his CV. Professor Sirichai Adisakwatana is current staff at the Department of Nutrition and Dietetics at the Faculty of Allied Health Sciences, Chulalongkorn University. He is currently the chairman of Master and Doctoral Program in Food and Nutrition, International Program, Faculty of Allied Health Sciences, Chulalongkorn University. He served as a board and advisory member of the Nutrition Association of Thailand under the patronage of Her Royal Highness Princess Maha Chakri Sirindon. He has been recognized for his work and bioactive phytochemical compound with the Young Research Award. So actually, that I read, Professor is focused on the phytochemical compound. Okay, actually, so many experiences, also publication. So please welcome Professor Sirichai Adisakwatana. The time is yours.
Yeah, thank you very much. So first of all, I would like to thank you for the committee to inviting me to join these sections. So I'm going to talk about almost 30 minutes to share my research experience from Thailand and think about this band you recognize in Indonesia, especially you can use it like a functional ingredients. The topic is the Khichari alternative flowers as a potential source of bioactive anthocyanin-rich diet. So over the last 2 decades, the global health issue have become more prominent in foreign policy. The prevention and control of non-communicable diseases are one of the main challenges of the healthcare system around the world. So today, more than 1 million people die from the NCDs. So that's why there is the widespread international support for the fight against these diseases. But as you know, an NCD includes with the diabetes, cardiovascular disease, cancer, obesity, and hypertension. There are several risk factors for the NCD today. We know about the behavioral and dietary factors. So that's why they decided to try to set up the new strategy for prevention by motivate the people to increase consumption of healthy diets together with increased physical activities. So now, right now, scientists move forward to see how to use the raw material, especially from the local material is quite be good. Also, we can use for waste product from food and vegetable with the low price and costs, and together with new technology to transformations. The herbal ingredient also quite popular in Southeast Asia. They can add to the food together with the diet. That's the whole for reducing the risk factor for NCDs. So, however, there have some limitations of scientific data support of the products, especially in the clinical trials. Many scientists try to set up the clinical trial to prove that thing, because they hope in the future when they get the scientific data, they can submit to the government to show the functional claim or health claims. So today I'm going to talk to one herbal medicines, as you know, the Mangga Telang in Indonesian language. And in scientific name is called Khichria ternate. The common name is the blueberry butterfly pea. It's in the family of Fabaceae. It has been shown that traditional Ayurvedic medicines use the root, seed, and leaf for memory enhancer, anti-stress, anxiolytic activity, antidepressants, and also used for sedative agents. But in the food application, the is commonly used as the functional ingredient, especially from flower, because they contain the colors of blue and red and contain with high phytochemical compounds. So this is a form of the commercially available products. Somebody use the fresh one, somebody use the air dryings and mix together with the food, or they use for make the beverage. Some company use the air dryings and soak into waters, then into the liquid form. Then finally, they use the technique of spray drying and fish drying to be the solid particles. So this slide shows you the applications of Khichria ternate at the food colorants and also make the beverages. And look at that, and in various types of desserts. In Thailand, it's quite popular to add the blue pea together with sticky rice and eat together with the mangoes. So what about the phytochemical compound in these plants? The major antioxidant found in the Khichria ternate flowers we call as the ternitins. This is a group of polyacetylate of derivatives of definins together with the sugar compounds. There are many types of ternitins, including A1, A2, B1, B3, C2, and T1s. So we think about we should set up the hypothesis to prove the pharmacological actions of this plant, especially related to how to prevent the NCDs. The first, my hypothesis we set up about this Khichria ternate may inhibit carbohydrate digestive enzyme and leading to the reduced glucose absorptions. So I'm going to show you the major mechanisms of carbohydrate digestion. When you intake the carbohydrate-rich diet, starch may be hydrolyzed by the pancreatic alpha amylase to provide the monosaccharide, for example, maltose, maltose, and dextrin. In the other way, you can add the sugar into beverage. For example, sucrose. This is one of kinds of the disaccharide that finally in the small intestine, alpha glucosidase will react to hydrolysis of disaccharide to provide monosaccharide. That is time ready to absorb into our system via the sodium glucose powder 1, glucose powder 5, and glucose powder 2. In our publications show the effective protein of this extract. We use a water extraction from blue pea, and we know that the blue pea effectively inhibit the pancreatic amylase and alpha glucosidase activity. This cause of delay of carbohydrate digestions. So that is in vitro experiment data. We're going to move to support by the clinical study by set up to hypothesize of postprandial glycemic response from the Khichria ternate beverages. So that experiment, we provide the beverage containing the sucrose together with blue pea extracts. And the other groups, they drink only the blue tea extract without the sucrose. Finally, we collect the blood sample to determine glycemic response and antioxidant status. Okay, look at this figure, show you the types of error we have from this study. The all is a blue color contained with the Khichria ternates, and 2 kinds of beverage contained with the sucrose 50 grams. The extracts contain a total polyphenol about 50 milligram gallic acid equivalents. Okay, look at to the graph to glycemic response in the figure A. I show you after you drink, the participant drink that 50 grams of sucrose, the rise of plasma glucose concentration rise to at the 30 minutes after consumptions. But however, when we add together with the keternity, they suppress the rising the postprandial glucose at 30 minutes. And then totally look at the graph number C. They show you area under the curve. This is confirmed that this actually can inhibit alpha glucosidase enzyme because we use the sucrose as the compounds. And however, if you drink alone of keternity, that did not cause the hyperglycemia in the fasting state. This is quite be good for everyone. What about the antioxidant status? We know that if we drink the sucrose alone, the effects to plasma antioxidant capacity. If you look at the graph number A, after you drink sucrose alone, that decrease of antioxidant capacities after 30 minutes until 180 minute consumptions. Interestingly, when we add the keternity together with the sucrose, we found that this can maintain the antioxidant activity comparing with the sucrose alone. On your right-hand side, in number B, figure B show you the MDA. The MDA is the malondialdehyde. It's generated from the oxidative stress from the sucrose consumptions. When you look at the graphs after 30 minutes, the rise of the MDA concentration show at this period. But the keternity can suppress of the MDA generation from plasma concentrations. What about the finding from this study? We know that after we drink keternities, they can increase the plasma antioxidant capacity and without hypoglycemia in fasting state. And this also improve the postprandial glucose, insulin, and antioxidant status when you consume with sucrose. But I do recommend to gain the optimal benefit from this study. I do recommend everyone should drink keternity prepared without the sugar and drink together with the milk consumptions. For next step, not only for carbohydrate digestion, we also think about for postprandial lipid metabolisms, how the keternity can improve the postprandial lipid profile. For this study, we think about postprandial, this metabolism. This is a major cause to induce oxidative stress in obesity, in type 2 diabetes. When the oxidative stress increases in our system, may be cause of induced inflammation process, endothelial dysfunction, and finally, they increase the risk of cardiovascular diseases. One of our publication we mentioned about the keternity also have potential to reduce postprandial lipemia and increase plasma antioxidant, respond to high-fat meal challenges in overweight and obese participants. On your left-hand side, I show you the types of high-fat meal we investigate in this study. And your right-hand side, we add the keternity in the beverages. The results showed in the figure A, after the participant intake the high-fat diet at 3 hours, the rise of plasma serum triglyceride increases at this point. But however, when we add together with keternity, the totals of area under the curve of diacylglycerol decreases for 6 hours. In the figure C, also show you the plasma serum free fatty acids. We found that at 6 hours, keternity can suppress of rising postprandial serum free fatty acids, comparing to the high-fat meal. About the antioxidant enzyme, we also do examination in this study, especially in glutathione peroxidase. This is enzyme used for eliminate hydrogen peroxide, and the other organic peroxide, such as lipid peroxides. We found that after we intake a high-fat meal, the cause of reductions of plasma glutathione peroxidase activity at 180 minutes. But however, the ketogenic alternative, when we add together with a high-fat diet, they led to increase the postprandial plasma glutathione peroxidase activity in this period. So finally, this is conclusion. If we add ketogenic alternative together with high-fat diets, they help to delay the diacylglyceride rising in the blood circulations and also reduce free fatty acids. In the same time, the plasma antioxidant activity also maintain and improve after drinking this beverage. For overall, for improvement of postprandial, this metabolism can reduce risk factor to develop the cardiovascular diseases. This is our study show you about the postprandial nutrient metabolism. Now I'm going to move to the other study about anti-glycation activity of the ketogenic alternatives. What about anti-glycation activity? Okay, let's back to the basic backgrounds of education about diabetic complications. When the people who are diabetic cannot control glycemic very well, they cause induced protein glycation mechanisms. The protein will be act together monosaccharides to provide advanced glycation end products and together to generate a list of the oxidative stress. This is cause of development of diabetic complications, stroke, heart attack, cataracts, or glaucoma. What we found from our publication is very quite interesting thing. When we add the ketogenic alternative fiber extract together with fructose and protein albumins, this is help to reductions of glycation activities. They reduce the formations of advanced glycation end products and together to prevent protein oxidation to damage for albumins. So our findings suggest that this extract might be candidate for plant extract for prevent monosaccharide-induced glycation and oxidative damage to the proteins. Another published also proved the methyl glyoxal. The methyl glyoxal, this is also intermediate reactive agent from protein glycation mechanisms. In diabetic patients, we can find the methyl glyoxal show higher than for the normal people. If we allow the methyl glyoxals in the plasma glucose in the plasma concentration, maybe cause of induced glycation very fast comparing to the monosaccharides. When methyl glyoxal interact with the ricins, they will provide the reactive oxygen species, superoxide radical, hydroxyl radicals. We found that if we add the ketogenic alternative fiber together with this system, the extract will be trapped the methyl glyoxal to reduce the activities of protein glycation. Finally, we found the protein glycations and oxidation into the protein reduced from this system. So that is for in vitro and human study about the pharmacological actions of the ketogenic alternative. Now I'm going to show you in the food application. You can use this system in your homemade, or you can modify your food with the functional ingredients. This slide shows you our publications. We add ketogenic alternative into the meat products because of when we use the cooking method with the ovens, they can generate the protein and lipid oxidation. So this is caused to reduce the shelf life of from the meat products and also get some side effect from toxicant reagents. So that's why we try to add this functional ingredient together and mix together and cook it by oven and keep in the refrigerator. What we found from this application, you look at in the graph of malonaldehyde, at the day 0 until the 12th day, they increased the malonaldehyde product in the cooked pork patties. But however, if we add chytria alternate together this meat product, they can reduce from MDA formation in the refrigerators stored until to 12 days. This is one of application you can add the chytria alternate together with meat product as you want. This is the practical applications. They show you the blueprint to the meat industry in development of novel healthy meat products. They can improve the shelf life and store product without affecting all other qualities and hence making to consumer healthier. I also proved that the chytria alternate also used in the carbohydrate-rich diet. In this study, we fortified the chytria alternate extract in the sponge cakes. So look at in the figures, when we add the chytria alternate from 5% until 20%, the color will turn to the blue and dark colors. And what we found from biological activity from these products, as you know, when we induce the heat product to the sponge cakes, there will be generated malonaldehyde. Look in the graph in the control groups. If we add the chytria alternate from 5 to 20, they cause a reduction of T-bar value. So that means the chytria can be used to replace wheat flour to make the sponge cakes. And at the same time, we prove that the chytria alternate has more bioactive compound and good antioxidant activities. They help to reduce peroxidation in sponge cakes. So this is overall acceptability less of control. When comparing with and without that, the sponge cake were comparable. I also use for another thing to add to the wheat flour to make a bread. Look at the figures when we add 5 to 20. This is confirmed study for the chytria alternate can apply to various types of the diet. When we add the chytria alternate together with starch and making the bread, we found that chytria alternate can delay the carbohydrate digestion. Look at in the graphs, and we can reduce the glucose release from the bread products. And another thing, you may use this chytria alternate together with the rice or sticky rice, that we're going to prove that the chytria alternate, when we add to the rice products, in this here, we use cooking rice by cookers and microwave oven. It's the same method. We got the same color, again, same facility. And what we found from this study when we add chytria alternate flour together with the rice products, both of the cooking rice method, domestic cooking rice method, use a microwave and cooker, we found in the same results. The chytria can reduce the in vitro starch digestibility of cooking rice without effect of hardness of the cooking rice. And also reduce the stickiness of cooked rice were observed in this study. When we comparing with the sensory acceptability, we found that even you add the chytria alternate in the rice product, we get the same things, not different from scoring. So this is a first application that's provide to the people to understand how to use the chytria alternate in daily life. But however, one thing we have to concern is the stability of polyphenol in the chytria alternate in gastrointestinal tracts. Because of anthracene-rich product, they have some problem with the limitation of stabilities, bioavailability, and metabolical activity after you intake to our gastrointestinal tracts. This is caused of when we intake the polyphenol may not reach to achieve the pharmacological actions in blood circulations. Then we try to resolve this problem by using the encapsulation methodologies. The chytria alternate can combine together with arginate and add into the calcium chloride to make like the microbit system. So next slide, I'll show you the our innovation products we made from the arginate criteria alternative bead on your right-hand side. What we found from this study after we making the microbit system, when we add the microbit system, they can prevent damage of the gastrointestinal tract juices. On your right hand in criteria alternative bead, we found that when they move to intestinal phase, they can release a higher concentration of polyphenol in gastrointestinal tract juices. This is proof that in our system can prevent criteria alternative damage from gastric juices. So finally, from this study, you can use this application to apply with the herbal medicines as you want, because we use the easy system to encap the criteria alternative using with the calcium arginate bead. And after that, we know that the encapsulation can retain polyphenol and antioxidant activity and help to increase the pancreatic alpha malase activity after digestion. And finally, this is very surprising because after encapsulation, this technique, the criteria alternative also increase activity to bind to the bile acids. This is help to reduce the cholesterol digestion together. What about the practical application from this? We can add the micro encapsulation of criteria alternative in the fruit product, in jelly, in ice cream, or the yogurts. So that is all our experience to sharing today. What about the criteria alternative can be used as the functional ingredients in the products. So this is conclusion from our talk today. Criteria alternative show various biological activities and contain with the anthocyanin ternatin. This is a derivative of definitions, and they can offer as the national ingredient for development of healthy food products. Thank you very much for the talk today. If you have any questions, just feel free to ask them.
Yes, thank you very much, Professor. Yeah, actually, after this, we know the butterfly pea flower is very useful for us. Actually, for me, I don't know very much. And then it's like usual flower in the street. Okay. Mrs. Afrinia, want to ask something? Please,
Okay,
welcome.
thank you, Mr. Noor. Good afternoon, Mr. Sirinchai. Nice to meet you.
Yeah.
It's a very interesting knowledge that you're sharing. I have 3 questions, if you don't mind to answer my question. In Indonesia, it's also exists the butterfly pea. It's called bunga telang. In Indonesia, called bunga telang. Yes, and it's applied in many various products too. The first question is, as I know that NCDT level can influence the brightness of color in the solution of the butterfly pea. In what level of acidity that can be make the solution stable or consistent? That's the first question. And the second is, if we use this butterfly pea flower to be a functional food, how many butterfly pea that we needed to edit, maybe in grams, milligram, or milliliter or liter, so we can claim the product is a functional food. And the third is, if we use heat to make product with butterfly pea, in what degrees of Celsius that the product or the content of polyphenol cannot destruction or maybe reduce in the product. So we can claim the product with the functional food too, because the content of polyphenol in butterfly pea. Thank
Okay.
you, Mr. Sirichai.
Yeah, thank you very much for your question. For the first question, you're going to ask me about how to keep ketchup eternity beverage because of you worry about the stability. That's right.
Yes, right.
Okay, actually, when you make the beverage from kitchen eternity, so just avoid from the sunlight. You can keep in the bottles and keep in the refrigerators. And in my suggestion, if you want to keep the anthocyanins retained in longer times, you can add like the antioxidant compound, for example, vitamin C together. When the vitamin C add to this product, the color will turn to the red one. Because we know that if you want to keep this form in pH lower than 5, maybe 3 or 4, this is good for antioxidant stability. So I'm going to recommend to keep in low pH, right? Well, the second question about the functional ingredient, that's right. Again, please.
Yes, yes. But functional food, how many butterfly we needed to add it to the food that we can.
All right. Okay. In our study, we make like the spray dryer techniques because we think about if we add the fresh ones or use the water extract and add into the diet in regularly, it cannot show the beneficial effects in that one, especially in effect in the health system. So this is a limitation because we know that we need to add high amounts of ketchup eternity into the products to show the functional ability. So I do recommend that you can use and just like add to in the diet. That's the best way you can do. But I do not recommend to eat like dietary supplement because of the dietary supplement, you need to get higher amounts of intake per day. To just prevent for NCD, I do recommend you may add like the same method you do that in the cooking process. Because I'm proved already, if we add like 1%, 2%, 5%, that is sure the best prevention of lipid peroxidation. Because we don't want to induce the lipid peroxidation in the diet. Because we worry about this kinds of product may cause we get some injury or health problem, that one. So finally, for the third question that you asked me about the functional property, I think it depends on if you want to submit the functional claims in your country, you need to read the guideline because in our system in Thailand, if you want to show the functional claims, we need to certify by clinical trial, maybe one of publications. For example, if I develop the new novel compounds from the ketchup eternity, I need to submit the clinical study to confirm that when we eat the ketchup eternity, they can show like a functional properties. In these cases, I can submit my document to the Health Ministries of Thailand to claim about the functional property because the drinkings of ketchup eternity can reduce postprandial glycemic response and also increase antioxidant activity. That is my point, because you cannot claim overall from your one publications.
Thank you very much.
Maybe
Have any
third
question?
question
Yes.
about the use of heat in the product. What in the degrees Celsius that we can avoid the destruction or reduce polyphenol in the product with the butterfly pea if we use the heat.
What about heat is?
Heat maybe in product boiled in like the product bread, like bread or maybe rice.
Okay, as a cooker, right?
Yes, as a cooker. Right.
Okay, actually, it's okay. In the temperatures, I got the data from the machine. the for melting points of Khichari alternatives, especially for anthocyanin. You can increase the temperatures to 100 or not over 140, not over 140, because 140 Celsius tricky, because they will terminate of some compound, especially anthocyanins. Because even in sponge we got information about they can reduce malonaldehyde. But if you look at the colors of the sponge, they change from blue color to green one. That represent the damage of the anthocyanin structures. But we need to prove that when anthocyanin destroy to the other molecule, they will show the same pharmacological actions or not. That we need to prove that hypothesis further.
Okay, thank you, Mr. Sirichai.
Thank you very much. I guess it is clear, right? So we continue to another question. Ms. Kuntari, yes, you can ask directly.
Okay, thank you very much, Mr. Nur Adrian Insan. Hello, Professor Sirichai. Sawadika, Chan. Such a great explanation from you. Actually, I also have 3 questions. May I? Okay. The first question is
one by
about
one, please.
Okay, one by one. Okay, Chan. The first question is, does clitoral alternate has a similarity mechanism with the low glycemic index foods? So it means that they also can have the same effect as low glycemic index food.
It's not similar because of glycemic index. We provide to determine the diet containing with the starch product, but this pen is no contents of starch in the diet in the extract. We use water extractions. So then the mechanisms of Khichari alternative, we found that in the major point is they can interfere with carbohydrates digestion and absorption system. So that's why I try to motivate for everybody, because if you hold the Khichari alternative after absorption and show like a pharmacological action in pancreas or in the liver, it's very quite difficult because they have some barriers of bioavailability. But in the meantime, if you intake a lot of Khichari alternatives in your small intestine, that is the first organ to hydrolyze of carbohydrate. You can prevent the rise of postprandial glucose in this system, so that you can apply high amounts of Khichari alternate as you want. But however, thinking about the toxicity, because when you intake a higher and higher, more than 1 gram or 2 grams a long time, maybe affect to the renal system. So in my suggestion is you can drink the Khichari alternative maybe together with the meal, maybe one meal or 2 meals in the breakfast or the dinner. That's it. They can prevent the delays of carbohydrate digestions.
Chan. So it means that in the future, we will gonna have such a study to focus on the upper levels of consumption for the clitoral alternative. Okay.
Right.
And the second question is, as your explanation about the endogenous systems effect from the CTE for the antioxidant defense system. So we know that there are so many vitamins and minerals will affect to the system. So in the daily basis, is there any possible interactions between CTE with other nutrients, vitamins, mineral, or even bioactive compound, so that may contribute to the mechanisms?
Okay, that is a good question. I have no idea about that. I never try with a vitamin C together with Khichari alternative, but I tried Khichari alternative together with other herbal medicines. For example, maybe I could not remember the name. Okay, just one add together. When we add together and set up the system for inhibit pancreatic alpha amylase, when we add Khichari together with the other pan, they show synergistic inhibitions. When you get 1 by 1, not for equal to, there are more than 2. more than 50%. That be possible to show additive and synergistic effects.
Okay, thank you. And the last question is, so in the dietary applications for free living individuals, what your recommendation for the best suitable diet, for prevention of NCD together to boost the benefit of CTE? So what kinds of common dietary suitable recommendation?
Okay, when we think about in our traditional eating behaviors in Southeast Asia, these plants are used for make like a beverage. So this is the best one I do recommend if you want to get more optimal health from ketogenic alternative. You can make like a beverage. Maybe use 4 or 5 fresh petals and boil into the hot waters. You can drink together with the meal in the morning, in the afternoon, and in the evening together with the meal. Because we hope that ketogenic alternative, especially from anthracene, effectively inhibit this enzyme and reduce the postprandial glucose rising. This is good for the diabetic patients. But finally, I emphasize when you make like a beverage, do not use high amounts of ketogenic alternative, right? I would recommend maybe 4 and 5.
4 and 5.
Yeah, 4 and 5 petals.
Okay. Thank you very much, Asan Sirsai. Thank you, Mr. Rian.
Okay. Okay, maybe one last question. Okay, maybe I will translate it from Ivana Fardia, Prodi Nutrition Department, Stikers Mitra Keluarga. Okay, what is the factor that we need to consider if we add butterfly pea flour to the food? Is it the nutritious fact in the product will be have an optimal nutrition, or it will change?
Okay, actually, when we look at the functional ingredient, this one, I also analyze the nutrient compositions because we worry about if the ketogenic alternative has higher of the starch, it's not good for addition to the food. But however, this method we use the water extraction so that we provide only the anthocyanins in the product. But we also check with the sugar containings. This is quite low level for sugar products. And we didn't found the liquid profile in these extracts. So then when you add into the products, into the diet, don't worry about they do not change the nutrition qualities of the food, but you get higher potential for biological activities. But think about with the amounts of use of ketogenic alternative when you're cooking with the rice. Some people didn't like it because of when you add a lot of ketogenic alternative, maybe affect the stickiness and hardness. So it depends on the water used in for the cooking rice. So I do recommend you can try this at home and adjust your methodology as you want, and you would love to that sticky rice or cooking rice as for the sensory analysis by yourselves.
Thank you very much. Also, the last answer also maybe answer the last question, Marifanur Azhara, about the combine the flour with the rice. So okay, the time is up, and maybe I will resume the topics. Because this conference entitled about innovation health. So all of the speakers has so many innovation. So for Prof. Sirichai, he create a combination to the functional product for the butterfly pea flour. So yeah, also because this flour has so many benefit for us, antioxidant, anti-diabetic. Also, the professor create cookies, patties, rice and bread, and so many products. So it's so innovative. Okay, thank you very much, Professor Siricaya Adesakwatana.
Thank you very much for everyone.
We can meet again in the next occasion. Maybe we can go to Thailand, or maybe you can go to Indonesia. So
Yeah, you're welcome all the time.
thank you very much, Professor Siricaya.
Goodbye.
Bye-bye. Okay, thank you very much. Now we continue to Miss Dr. Is Helianti MSc. Are you there? Yes, thank you very much. Okay, I will read the CV of Dr. Is Helianti. Wait a moment. Okay, Dr. Is Helianti MSc, Pusat Riset Mikrobiologi Terapan, and after I read the CPC, create so many enzyme recombinant with the microbiology technique. Bachelor program from Tohoku University, master program from Japan, master and doctoral program from Japan Advanced Institute of Science and Technology. And if we can see for the research that held by her, it's so many, and mostly she created the enzyme, recombinant enzyme. And we know that enzyme is so many application for the product, innovation product. So please welcome Dr. Is Helianti.
Okay. Can you hear my voice? Hello?
Yes.
Okay.
Yes, doctor.
Yeah. Thank you very much, Pak Nur, for the introduction. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Thank you very much for the organizing committee for inviting me to this conference. Today, I'd like to give a presentation about the mini review of the application of microbial recombinant enzyme in pharmaceutical fields. And I also will introduce some of our research related to this term. I think we all know about the enzymes, or at least we have heard about the word enzymes, right? Because maybe we have learned about it in senior high school, for example. Enzymes are biocatalyzed, and they are proteins that produced by living cells. So because we are human beings, we are in our body, enzymes are also produced. They catalyze most all chemical reaction in living cells. And because of their biocatalyzed function, nowadays they are employed in various chemical reactions as biocatalysts in many applications. I will mention about the interesting facts about enzymes. Actually, as from a biological aspect, human being is animal, right? We are primate, and as a civilization, human, the enzymes also important. If in our bodies there is predicted about 1,300 kinds of enzymes, and if there is no enzyme in our body, exactly we all die. Why? Because without enzyme, it will take 2 million years for digesting food. So if we ate the food this morning at 7 o'clock in this morning, so it will be used as nutrient after 2 million years later. So for us, it's forever. So we cannot imagine if there is no enzyme in our body. And in our daily life, enzymes are also very close to 700 products in our life. Yeah, there is enzyme help in our consuming product everywhere, There is enzyme help in paper that are we use for writing, for book, or there is enzyme help in detergent we use to wash our clothes this morning, or there is enzyme application even in the cosmetic as women we use before we go to the office. So there are many applications of enzymes in our everyday life, and enzymes also have economic value. If we take a look to this picture, the global demand of enzyme is increasing year by year. This is the general enzyme, industrial enzyme. If we focus on specialty enzymes, what is the difference between specialty enzymes and technical enzyme? Specialty enzyme is applied in specific field, for example, for pharmaceutical, for diagnostic, for biotechnological research, and it is a very specific application, and the purity is usually higher than technical enzyme. So the demand of the specialty enzymes in the world also increasing year by year. It is not only happening in one country or in one continent, but it's happening in all over the world. So the demand of specialty enzyme is increasing. And
Doctor,
if
I'm sorry for
yes,
disturbing you because the slide is not running.
okay,
Maybe like setting slideshow or something.
yeah. Oh, but
Yes.
in my laptop it's
Okay. For us, it's like a slide number 1.
okay. So is it I should stop the screen, so for the from the committee we
Okay.
hold the
Okay.
I stop the sorry.
Yeah. Yes. Yes. Sure.
Yeah.
The committee will slideshow your PPT. Yeah. You just ask next if you want to go to the next slide.
Okay. Sorry. It's already fourth slide.
Slide 4.
Yeah. The next is okay if I go to the next to save the time.
Sure, doctor.
Yeah. Yeah. Next. Next. I didn't see any movement. Next, please. Next, please. Okay. This slide. Yeah. I mentioned in this slide is about the source of enzyme, because I stated before that enzymes are produced in living cells. So living cells are include plants, animals, microbes. But if we take a look to the global enzyme markets, the more than 80% enzymes, commercial enzymes, is coming from microorganisms. Why this happen? Yeah, because this next, yeah. Next, please. The microbes is the creature who's the highest population and highest diversity on Earth, yeah, because we can find microbes in any biosphere. We can find microbes on our skin, on our digestive system. We can find microbes in soils, in river, in ocean. Even we can find microbes in the very extreme environment, in 100 degrees Celsius temperature of crater, in very acidic crater, or in very alkaline hot spring. So we can say that microbe is everywhere, and they are abundant population. So the microbes is sustainable enzyme resources, and the microbes is economically feasible as producer of enzymes. Why? Because microbes can be cultivated and produce enzyme at large scale, but at limited space and short time. Maybe we can take an example. If we obtain the enzyme from plants, for example, maybe for harvest the plant, we need a very large land. Maybe we need 100 hectares of land. But in the case of microbe, we only use maybe the bioreactor that only needs space for about 300 meters square, for example. Next, and microbes also, I already mentioned, they have a high psychological, geographical, and genome diversity. And the enzyme they own have a huge catalytic potential. And the enzyme from microbe is also can be extracted and purified easily. Microbe can grow faster in huge amount in a bioreactor, and the most important, microbes can be easily manipulated to increase the enzyme productivity by, for example, the recombinant DNA technology. Please, next. Next, please. And how are enzymes produced in lab scale or in industrial scale? Basically, there is no far differences between enzyme production in a lab scale or in industrial scale. Usually, they need the following step: microbial screening and isolation, fermentation to obtain enzyme target, and upstream technology, including purification, enzyme concentration, and so on. However, maybe in the process, the wild type microbial enzyme is not enough. So we have to apply recombinant DNA technology. Why recombinant DNA technology important? Because using this technology, it is possible to increase enzyme productivity. And if the source of enzyme is dangerous for human being because it is pathogen or it is contain toxic or etc., we can only take the target gene enzyme, the target gene encoding enzyme, and produce the enzyme in other hosts. And if the wild type that producing enzyme is maybe difficult to handle, we can also move the target gene into the other host. And we can also conducting the protein engineering to improve the traits, the character of the enzyme. This is possible because recombinant DNA technology. Next, please. Now let's move to the example of enzyme that are used as drugs or as therapeutical enzymes. That nowadays we patients in the hospital is consuming this drug. There is L-asparaginase enzyme that used nowadays as anti-cancer. Also, there is ceratiopeptidase that used as anti-inflammatory agent. There is streptokinase as dissolving blood clots agent. There is collagenase as burn wound healing drug. So there are several enzymes that already used as drugs. Next, please. There is also enzyme that used as enzyme supplement. There is digestive enzyme based on herbal or microbial resource. There is also nattokinase. This is also supplement from Japan. That is this is a kind of fibrinolytic enzymes that coming from functional food from Japan, coming from natto, and they are this product belief can prevent heart disease because it can it's kind of fibrinolytic enzyme, so it can dissolve the blood clots. Next, please. So let's focus on the L-asparagine as a drug to fight acute lymphoblastic leukemia. Usually, this leukemia happen in children, yeah, and the use of L-asparaginase is become a chemotherapy for this blood cancer. L-asparaginase degrade L-asparagine into L-aspartate and ammonia. In normal cell, all cells need L-asparagine to grow, to propagate, yeah. But only normal cell can make L-asparagine by themselves. The cancer cell cannot make the L-asparagine by themselves. So if we add L-asparaginase to the cancer cell, the cancer cell that with exogenous L-asparaginase will be starving. So finally they will die. That's the mechanism why the L-asparaginase is used in leukemia cancer. Nowadays there are 3 types of asparaginase. Yeah, asparaginase that come from E. coli, L-asparaginase that come from Erwinia chrysanthemia, and modified asparaginase from E. coli, but modified by PEG, pegylated asparaginase. But in my opinion, we still need asparaginase from new resources. Next, please. So several years ago, we conducted to do research to search L-asparaginase from other resource than E. coli and Erwinia chrysanthemi. So we isolate the gene encoding L-asparaginase from Bacillus subtilis. Next, please. And we also isolate the gene and express the gene of L-asparaginase in from Erwinia rapontici, and we express it in E. coli. Next, please. However, unfortunately, our research is stopped by many reasons, because research of enzyme for drug is long way journey. It is not only to get the potential enzyme, but we have to do the efficacy, the in vitro, the toxicity assay, and if we successful, we can continue the in vivo trial, and if we successful, we can try to the clinical trial. But many of drugs may be stopped in some of this level. Maybe there is a drug that already good in vivo trial, but cannot continue to clinical trial. And in anti-cancer drug, there are many orphan drugs. So because the budget for research is very expensive. Yeah. So although the research of enzyme product from microbe is a long way journey, I believe the microbial production of therapeutic enzyme is both economic and eco-friendly. Yeah, especially if we compare with chemical therapeutic, they are eco-friendly in the process. So I think we have to continue the spirit to find the new therapeutic enzyme. Next, please. And in this slide, I'd like to introduce other function, other application of enzyme in synthesized drug. This is, I take an example of ibuprofen drug. We know this drug is for decrease fever or to relieve pain. Yeah, and until 4 decades ago, the commercially available drug is RS enantiomer resmic. of the ibuprofen. Actually, from the pharmacology aspect, only as ibuprofen that effective to fight the fever or relieve the pain. So if the mixture, it's not good for our health actually. So in this case, lipase have the reaction. So the racemic of SNR ibuprofen can be separated, and we can get of only we can only get the S ibuprofen. Next, please. And there is also an example of enzymes that used to synthesize beta-lactam antibiotics. Next, please. The enzyme names is penicillin G acylase. These enzymes is actually already used since about 60 years ago to synthesize amoxicillin, ampicillin, and other beta-lactam antibiotics. Nowadays, they are also used to make a modern beta-lactam second or third generation of beta-lactam antibiotics. In brain, we are also doing this research, but not but for publication we don't have any until now. But we are doing the production of this enzyme. Next, please. And the last application is the use of enzyme as protein target for screening drug candidate or for drug discovery from the herbal or other resources. I take an example our research about the production of SARS-CoV-2 protease as a protein target to screening drug candidate from herbal and microbial resources. We know that COVID-19 virus has genomic information RNA. Yeah, RNA is transformed into polyprotein, and this polyprotein is not functional polyprotein unless they are cut by PL protease and 3CL protease. So these two proteases cut the polyprotein, so the viral protein can be functional protein. They can be envelope protein, S protein, etc. And they form a new viral particle. So this protease has significant roles in replication virus, replication. So if we can inhibit this protease, the activity the protease, it means we can stop the virus replication. So this why these enzymes are used as protein target to find active compound for herbal for other resource that can inhibit this protease. So if the active compound can inhibit the protease, it means it can inhibit the virus growth. Next, please. So in our research, we produce 3CL protease by technology DNA technology recombinant. We take the gene that encoding 3CL protease, we express in E. coli, we purify the enzymes, and we do the assay of kinetic parameter assay. Next, please. Yeah, so in this experiment, we try to compare our protease with commercial protease, and we found that our protease has a similar characteristic with the commercial one, so it's okay to be applied as a protein target. And we also try to add quinidine to the mixture, and we find that this quinidine inhibited the protease activity. Next. And our team also doing in silico inhibition screening by docking, molecular docking. And we find from this in silico experiment that meniran is very potential to inhibit the SARS-CoV-2 protease. But so far is only the computational research. So we have to confirm that is it really the meniran can inhibit the protease. We have to do the next experiment, but I cannot show you the result right now. But we are also excited to see if this meniran can inhibit the protease, the SARS-CoV-2 protease. Next, please. So I think as a conclusion, microbial enzymes show significant potential because of their biocatalyst activity and promise huge application in the pharmaceutical field, from drug discovery to industrial manufacturing. And I believe we have to do this research in Indonesia, although this is the long way research, but we have to conduct this research because we have many source of microbial diversity that may be very important research for resource for this kind of enzyme. And thank you very much for your attention.
Thank you very much, Dr. Helianti, for nice presentation. So we are also interesting for you. Now your plan is like create the drug for COVID-19, right? Inhibit
Yes,
COVID-19.
yeah. Actually, not only our team, but we are in collaboration with Fakultas Farmasi of UI, and we are also in collaborating with E3L, ELL, yeah, in doing this experiment. Yeah.
Okay. Okay, from participant, if you have any question, you can ask directly or chat in the chat box, Zoom or YouTube. Or if you want to use Bahasa, also okay. Okay, if no, maybe, yeah, we will waiting for another participant to ask. For me, I have like, I see you create the, I don't know, is it correct or not? You create the vaccine before, I mean, vaccine for, I don't know, for bacteria or for
No.
virus? No, okay.
No, I didn't. Yeah, I
drug
didn't make
compound.
vaccine. Yeah.
for
Actually,
COVID-19.
my expertise is enzyme. So I applied enzymes for health. Yeah. For example, use it as a therapeutical enzyme or drug. And we also make enzyme as protein target to screen the drug.
Okay. So is there any product that, or maybe what is your update in your team for your product, enzyme product? And is there any product that already commercialized, or in which step, if not commercialized, or maybe in which step your product is now?
Okay, thank you. For commercialization is very difficult, yeah, especially if it is related to drug, because maybe other speakers already mentioned that there are tight regulation if we want to make the drug by ourselves. In our research, maybe we are not in the step of commercialization, but our products such as 3CL protease is now is being used for protein target in screening of herbal drug, candidate drug from herbal. Yeah, that's collaboration between Farmasi UI and BRIN.
Okay, and also if we see your CV and also your presentation, you create the enzyme by recombinant technique, and
Yes.
and now you are interested to meniran.
Yes, yes.
Okay, in what kind of research that you want to provide for meniran can inhibit COVID-19?
Okay, because we have project that doing screening candidate herbal medicine for COVID. So in this team, we are also doing the in silico experiment to see the compounds for some herbals maybe can inhibit the protease, SARS-CoV-2 protease. And in this experiment, by doing the in silico by molecular docking and by ADMEC, we found that meniran is a good candidate because there is many compound in meniran that have interact well with the active site of the protease enzyme. So from that in silico experiment, we have to continue if this meniran can be used as herbal candidate drug, yeah, from herbal. That's because
Okay, so
we do in silico experiment in many herbal source this time.
Okay, so first you know that in silico system for meniran they can inhibit COVID-19.
Yes, yes.
So in silico is like ini apa computational gitu.
Yes, yes, but it's only computational. We need
Yes.
further proof, yes, to make sure is this compound really can inhibit the protease. So we use our protease to do a wet lab.
Okay, cool.
Okay.
Is there any question from participants? You also can ask. Oh, from YouTube. From Melania Perwitasari. What is the promising using enzyme on developing herbal medicine?
Yes, as I described before, the enzyme is used as protein target. Without enzyme, maybe it's a little bit difficult to do screening the herbal. But with enzyme, the mechanism is clear. For example, in COVID, if we want to find the herbal medicine must stop the virus replication. So virus replication is caused by the protease. So we can inhibit the protease activity by some compound. It means this compound is the candidate of herbal drugs. That's so in this case, enzyme is not directly but it's used as protein target. It's supported the screening system. Is it clear?
Yes.
Yeah.
Yes. Mrs.
So I think
Melania.
it's not only COVID. It's not only COVID. We use enzyme, of course, another kind of enzyme in malaria, yeah, in cancer also. So it's usual in drug discovery process to use enzyme as a protein target.
Yeah, because we know that if we have enzyme product, in my opinion, it's kind of difficult. I mean, for stability is quite low, right? So it's kind of because it's not resistant to heat. Is there any, I mean, suggestion for you if we have product is kind of enzyme, because enzyme is like stability is not so good in the heat process.
Okay, okay. Maybe in protein targets, it is important to maintain the character of enzyme as it is. So we can improve the characters of the native protease. For example, in COVID, the protease character is like that. So we cannot change. But in other application, maybe in therapeutical drugs, yeah, maybe we need more stable enzymes. And in this case, we need the method that called protein engineering. We engineer the protein by changing the amino acid. So it is mean we change the DNA sequence, so we can get the desired traits. Yeah. That's the concept. It seems easy, but actually it's very long experiment. So we can do protein engineering to change the character of enzyme by do the mutation of amino acid by change the DNA sequence. That's what all the protein engineers do in the world. Yeah.
Very clear. Is there any question from participant, or you can text it in YouTube if you watch it, or you can text in the chat box, and also if you want, it's okay for asking with bahasa. Okay, if there is no, so also the time is up. So because we have 2 speakers now. Okay, maybe last question, Doctor. From Melania Perwitasari. From your experience, what is the challenge developing the herbal medicine? So she asked in YouTube because she's not join this.
Okay, actually herbal medicine is not my competence. We are in collaboration with the herbal prodi in pharmacy in UI. So I think the challenge, but I read some paper about it. I think the challenge of herbal is kita menjadi tuan rumah di negeri sendiri, gitu ya. Because herbal until now it cannot recognized as medicine. Yeah, maybe the level is only supplement. That's what I think. So that's our challenge to make herbal menjadi tuan rumah di negeri sendiri, because herbal is our culture, and I think herbal is also kearifan lokal kita gitu. That's the challenge, but I know that's maybe a little bit difficult, but we have tried. Yeah.
Yes, yeah, we need to go to become tuan rumah di rumah sendiri ya dengan
Saya nggak tahu
herbal
bahasa
medicine.
Inggrisnya apa soalnya.
Sama Bu, sama. Okay, so the session is done. So because we have 2 speakers now joining in our Zoom, so we can take a photo session first. I will invite Dr. Is Helianti, also Professor Abushed Musadek from Bangladesh, and then Dr. Susi Hartati as our head of Stikes Mitra Keluarga, also Mrs. Lina Heridapinem and Mrs. Lisbeth Pardede as our documentation. Also Mrs. Eka as a center of research and community engagement. Okay, 1, 2, 3, cheese.
Yes.
Thank you very much, Dr. Is Helianti, for
You're
your
welcome.
participation,
Thank you very much.
for your joining.
Thank you.
Very much.
Assalamualaikum.
Thank you, sir.
Waalaikumsalam. Yes. Okay, now we have last speaker. Professor Abushed MD Musadek from Department of Pharmacology, Uttara Adhunik Medical College from Bangladesh. He will present the title about bioequivalence. In Indonesia itu bioequivalency. Studies in Bangladesh, prospects and challenges. So maybe I will read the CV first. Bisa. Yeah, actually, he is our collaborator. We have 1 or 2 times meeting with him and university, and welcome in Indonesia, even with virtual Zoom meeting. Okay, Director Clinical Trials Affair, Quest Bangladesh, Dhaka, and also Professor and Head Department of Pharmacology, Uttara Adhunik Medical College, Uttara, Dhaka. Can you go down? Okay. Yeah, is Associate Professor, and also, now is Professor, and previously become Associate Professor and Assistant Professor from Uttara Adhunik Medical College. Right? So can you go down? Or okay. Yeah, current position now is Director, and professional experience, Head of Department, also Professor, Associate Professor. So it's so many experiences. So maybe we can go to his speech now. Professor, you want to share by yourself, or? So can you unmute? Sorry, Professor.
Okay. Can you hear me?
Yes.
I am the last speaker.
Yes.
In Bangladesh, I am the last person who will leave after this speech. Okay.
Thank you very much.
Time is expiring. Okay, I have to leave. Okay. Thank you for inviting me. Good afternoon, Dr. Noor and all other audience. My interest area, Noor has partially showed my CV. My interest area is the clinical trial and personal medicine. I am actively involved in the research, conduct clinical trials and personal medicine. Sorry, without making any delay, I would like to start my presentation. Thanks, Noor and the committee for inviting me, giving me opportunity to deliver this speech. My topic is bioequivalent studies in Bangladesh, challenge and prospects. First, I would like to about the definition. Bioequivalence, the property of the 2 dosage form active ingredients, similar blood concentration levels that produce the same effect at the site of the physiologic activities. Sorry. Products are considered to be bioequivalent when they are equal in the rate and extent to which the active pharmaceutical ingredient in abbreviated form API becomes available at the site or sites of the drug action. Importance of the BIE study. Generic products, which is also known as the multi-source products, must satisfy the same standard as those applied to the originator products. So it becomes the viability and bioequivalence now becomes the public issue, because the quality of the drugs affects the efficacy of the drugs, and efficacy of the drugs affects the public health. So viability and bioequivalence of the drug products is becoming the national and the international regulatory issue, also for the scientific issue. That is the market of the generic products, global market, actually the global markets. In 2008, it was only 81 billion US dollars. In 2015, it became 168.7 billion US dollar, with growth rate is 15%, near about 15% from 2008 to 2014. In 2016, it became 352 billion US dollar. In last year, 2021, it became 553 billion US dollars. Here is the growth rate from the 16 to 2021 is 8.7%. And the projected market size will be in 2023 is 1.52 trillion US dollar. Everybody we know that the drug price is in the highly developed country is the very costly, but fortunately in our country, like our other LDC country, it is much cheaper than the highly regulated and the developed country. For that purpose, the generic drugs will maintain its growth in the near future, in the coming year. Due to the healthcare cost and the cost of the medicines in the highly developed country, healthcare providers are facing the many challenges. Also, the healthcare receivers are facing the many challenges regarding the cost of the healthcare. So, multi-drug company to produce the cheap drugs, they are outsourcing it, which may be the one of the good destination for the for Bangladesh. In 2014, global BE market was only 31.5 billion US dollars. In 2015, it goes to the 35.3 billion US dollar, and in 2020, it became 46.8 billion US dollar. Unfortunately, I have not seen any data in 2021 or 2022. Now, I'd like to share some information regarding the status of the pharma industry in Bangladesh. Like the garment industry, everybody in the world knows that we are the pioneer of the garment industry, but pharma industry also is the most advanced among technology-oriented sector, which has developed over the last 5 decades. Almost all the drugs are producing from the high technology drugs are also produced, like the insulin, hormone, anti-cancer drugs are producing in Bangladesh. After implementing the national drug policy in 2022, drug industry, pharma industry is growing faster and faster. And look, Bangladesh is the only LDC country which has highly developed pharma industry. It is going to be the generic hub in Asia. I've mentioned that the Bangladesh is producing the lots of highly technology-oriented drugs in Bangladesh. Now, 98% of the demand are met by the local production, which is mostly from the National Pharmaceuticals Company. Domestic market in 2021, it was 3.2 billion US dollars. In the last 1 year, growth rate was 10.72%, 7.72%. And the last 4 years, growth rate is 8.93%. Total pharmaceuticals, registered pharmaceuticals company in Bangladesh is 284, but functional is 213. This is the revenue of the Bangladesh pharma industry. In 2017, it was above 2,000 million US dollar. In 2018, just after 1 year, it reached the 2,500 million US dollars. In 2019, it crossed the 2,500 US dollars. Now, in 2021, according to the statement from the 2021 provided by the BAPI, BAPI means the Bangladesh Pharmaceuticals Owners Association. In 2021, it has crossed the 3,000 million US dollar. Now, after fulfilling the global demand, local pharmaceuticals company is going to are focusing to export the their pharma products to the different countries. Now, mostly exporting to the less developed country or less regulated country, but topmost pharmaceuticals company are focusing to exports to the highly regulated country like USA, European Union countries, and Australia and other by fulfilling their criteria. Bangladesh government has declared the pharmaceuticals industry as the third sectors. Last 2 years, approximately 1,200 pharmaceutical products are received registration for the exports to the more than 150 countries. I informed you that the leading pharmaceuticals company are increasing focus on to the highly regulated countries like USA, Canada. I have mentioned the foreign clients are now interested to work with the local pharmaceuticals industry for the joint manufacturing plan. Establish the joint manufacturing plan. That is the prospect and opportunity. I have mentioned in the previous early slide that the after implementing the national drug policy in the 2082, Bangladesh pharma industry in Bangladesh is growing faster and faster. Last 5 decades, it has mostly developed and get the international accreditation. Now, it has also developed the skilled manpower, sufficient skilled manpower in Bangladesh. Also experience in CMO. CMO means the contract manufacturing organization activity.
Hey, Professor, I disturbing you.
Sorry.
Maybe you can slideshow because the text is quite small for us.
This is just pictures. I am not able to
yes.
Provide the big form. Okay, sorry. I'm telling the right which cost of the labor is among the lowest in the world, which is the lowest on the world. It is 3 to 4 times cheaper than India, neighboring India and China. And we have the TRIPS facility also. Local pharmaceuticals company has now focusing to develop the research and R&D, and they're focusing to conduct the clinical trials and some other research with the drugs. As a LDC country, like Bangladesh and all other LDC country now enjoying the TRIPS facility. TRIPS means the trade-related aspects of the intellectual property rights. It will be till 2033. Advantage of the TRIPS, which we are enjoying now. It is the only Bangladesh. I have informed that the Bangladesh is the only LDC country which has developed pharma industry, and Bangladesh is producing mostly near about the 80% are generic drugs and only 20% are patent drugs. With the advantage of the TRIPS, Bangladesh can export to any country if the medicine is not under patent. In that country, if it is not under patent, we can easily produce any drug and export to that country. Bangladesh can export opportunity. Bangladesh have export opportunity to other LDC country or non-WTO country that have not implemented the product patent protection. Bangladesh can export to a country where the patent holder have not filed for the patent. That means the multi-drug company has not filed for the patent of their invented products. Bangladesh can exports opportunity, has the export opportunity to a country that issued the compulsory license and awarded production contract to Bangladesh. It is like that if a company based in USA contact the CRO, that the contract manufacturing in Bangladesh, after production in the Bangladesh, this drug can be exported to the USA. Challenge of the BE study. Till now, there is no accredited, internationally accredited BE lab in Bangladesh. So far, I know only the 2 BE labs in Bangladesh, one in the Dhaka city, one in the northern part of the Bangladesh, but they are not independent. They are not independent. They are the under umbrella of the 2 pharmaceutical industry. So they will not get the international accreditation. Everybody, you know that the BE study is costly in the, especially in the highly regulated country, advanced country, and we have to wait for the long time due to the long queue, and they are not involving the Bangladeshi volunteers. What will be advantage of BE center in Bangladesh? It will sell foreign currency. It will improve the quality and efficacy of the medicines. I'd like to inform, share you that the United States Pharmacopoeia, in collaboration with the WHO and the DGTA, that means the Director General of the Drug Administration, which is the regulatory authority to see the quality of the drugs, in collaboration with the United States Pharmacopoeia, are working to improve the quality and efficacy of our medicines. They are keen to, they are interested to build up and the capacity enhancement of the BE lab in Bangladesh. They are also interested to establish a BE, finance to establish a BE lab as per international standard to Bangladesh. So advantage will open the opportunity in the field of research and development and develop the skill manpower. To promotion the pharmaceutical industry, especially into the highly regulated country and moderately regulated country. And of course, it will decrease the dependency of the BE centers in the other countries. And we have to wait less for the BE study results. Increase the awareness of the good therapeutic drugs. Of course, local peoples are very much aware, and if we able to establish an international standard BE lab, it will further increase the awareness for the good therapeutic drugs. It will help to increase the indigenous experience, training, and capacity building. And of course, a cost for the BE study in the cost of the BE study in Bangladesh will be cheaper. And the regulatory body, in that case, after establishment of the international standard BE lab in Bangladesh, regulatory body, DGDA, and the ministry will enforce the BE studies and BE data requirement, not only for the exports of the pharma products in other countries, but also marketing in the local markets. Due to the lack of the BE centers in Bangladesh, DGTA is not strictly enforcing the BE test regulations in Bangladesh for the marketing in the local markets, also exporting into the other countries. But DGTA as I mentioned earlier, that with the help of the some United States Pharmacopoeia and WHO looking for the upgrade and maintain the quality and efficacy of the drugs produced in Bangladesh. So if the BE center is established in Bangladesh, it would be a good argument for the local regulatory body to strictly enforce the BE requirement for the local manufacturers and imported products, which is important as well as the exported products. What will be the national guideline regarding the BE study? In 2016, DGTI has developed the clinical trial guidelines, but till now there is no clear-cut guideline for the BE studies in Bangladesh. We have to consider the following points to reach the decision established in the BE centers in Bangladesh. Support from the highest level, general environment, and of course, initially foreign support is highly demanded. Motivation of the all stakeholders is very much essential, and regulatory supports to enforce the BE studies from the DGTI and the ministry. Infrastructure have to be developed, but it is not very much difficult. Smooth, uninterrupted gas, water, and power connection have to be ensured. Qualified and skilled manpower and technology have to be developed. Developed, and the in the BE centers, scientific steps have to be incorporated. Most important is the initial period. International collaboration have to be. International collaboration is highly needed, and for the establishment of the BE centers, good quality in analytical instrument is badly needed. Besides that, the theoretical knowledge and awareness of the whole complex of the BE study have to be ensured, and the clinical trial feasibility facilities should have to be ensured. And now we have to find out the number of the BE study is conducting in at present. We have to involve the experts who are experienced in doing the sophisticated analytical work, troubleshooting, and data evaluation. And the most important is the manufacturers willing to do the BE studies on commercial basis in the local BE centers. And the very important point is that we have to follow the good clinical practice and good laboratory practice also. And we have to aware of the good WHO pre-qualification scheme, and we have to develop the good dossiers, and training have to be conducted regular basis. Political stability is important issue, and regional importance of the BE center, not only the work for the local pharmaceutical, but if we able to establish a BE center as per international standard, it will serve as a center for the neighboring countries. And the finance is the most important point. What with the status of maybe the status of the BE center? It should be the under regulatory control or independent. Independence is preferable. Autonomous for the regulatory authority and industry, attached to a industry or research center with good infrastructure, and under a center of excellence or affiliated it to or accredited to the DGTI and WHO or some other international organization. Committee. BE center should have the two committee, one for the good clinical practice committee and one for the independent ethical review. And the both committees should be recognized by the WHO. In a BE center, we have 4 units. Most important unit is the bioanalytical units, then the data management units, and then the quality assurance unit, we have to follow the good laboratory practice, good clinical practice, and the clinical pharmacology units. Bioanalytical units. I've mentioned earlier that it is the most important unit for the BA study. Should follow the good laboratory practice and the British standard or European standard. Here is the list of the instrument which is badly required for the establishment of the good international accredited BE lab in Bangladesh. LCMS, HPLC, auto sampler, software, refrigerated centrifuge, milliQ, water, microbalance or ultra microbalance, and GCMS. We should have the in-house medical laboratory equipped with the hematology analyzer, chemistry analyzer, with electrolyte analyzer, semi-automated chemistry analyzer, ELISA reader, coagulatometer. Some information regarding the clinical pharmacology units. We should have the 60-bed dormitories and 10 beds clinical trials beds. And we should have the, of course, IRB. And dedicated screening area with the physical examination and sample collection rooms. We should have the pharmacy, good pharmacy with temperature control. And we should have the dining room, recreation room, and the proper recreation facilities. We should have the multiple dosing and phlebotomy stations. And we should have a collaboration with the nearby hospitals or clinics who have the ICU facilities. We should also have the on-site processing laboratory with 70, -70, and -20 storage refrigerator, sophisticated clocks to facilitate the standardized times entries, and the backup generators, camera monitoring and recording for the international and interior and exterior of the facilities, computerized temperature monitoring system for freezers, programmed to alert the mobile call, and access control room, fireproof activities for the safe of the documents, walk-in refrigerators with temperature monitoring and alarming systems for the long-term storage of the study samples. Investments. We should invest for the installation of the equipments that I mentioned earlier in previous slides. Regular training is highly important, and monitoring evaluation of the daily work of the study is important. Initial 5 period, it is advised to follow up by the competent foreign experts. Running cost, which includes the salary and some other expenses. Quality assurance, it is one of the very vital points, units. Initial 5 period should be monitored, and all operations should be vigorously monitored by the competent foreign consultants, but daily quality assurance should be monitored by the local quality assurance manager and directors of the BE centers. Conclusions. As the conclusion remarks, BE center is the lifeline of the pharmacy industry. If we are able to establish BE centers to conduct the clinical BE study as per international standard, but in competitive price, it will become well established and well known in the region, not only for the national pharmaceuticals company, but also from the pharmaceuticals company nearby countries. In the countries of this region will use the service for the BE center. Thanks, everybody. I'm the last person, and in my office, I am also the last person. Okay, if you have any query, you can easily, I'll appreciate, you can mail to me. Also, you can keep in contact with Dr. Noor. He will inform me. Thank you for patience, Harry. Thanks for giving me opportunity to deliver this speech.
Thank you very much. So actually, because why the reason you are the last, because the established of the department. I mean, the pharmacy is the newest one. So the last speaker. Okay, so I guess so many questions from participant. So you can ask directly. I see in the YouTube, and also the person is already joined. Is there any question directly, or you can write in the chat box?
Okay, Mr. Noor, can I ask?
Yes, sure.
The Prof. Mossadegh.
Sure, Mrs. Melania.
Okay, good afternoon, Prof. Mossadegh.
Good afternoon.
Yeah, that you mentioned before about difficulties conduct bioequivalent in Bangladesh is there is a volunteer is not from Bangladesh. Can you explain more about that? Thank you.
Okay. I've mentioned that in Bangladesh there is no B lab, internationally accredited B labs. I've mentioned in that only so far I know only the 2 B labs in Bangladesh, but it is under the 2 pharmaceuticals industry, not independent. They are not independent. One is Novus, one is the it is under the premises of the one of the national pharmaceutical drug international, but they are not the internationally accredited. First of to establish the international accredited B lab, you have to be first primary requirement is this center must be the independent. But none of this lab is independent.
So it's because not independent that
no,
the
they are
problem.
not independent. So the WHO and the international funding organization, international accredited organization like the United States Pharmacopoeia. United States Pharmacopoeia is now operating in Bangladesh to improve the quality of the drugs in Bangladesh in close collaboration with the DGTA, Director General of the Drug Administration. None of them recognized it at the international standard, but they are assisting them to be independent or internationally accredited lab because there is no other lab in Bangladesh. So in future, I think they will get the international accreditation.
Okay, I got it. Thank you, Prof. Mossadegh.
Thank you.
Thank you very much for Mrs. Melania. So we continue to another question. Mrs. Ariska Devi, if you want to ask directly or maybe I just read it. I am Ariska Devi Anggarani. I would to ask about how to overcome challenges in achieving BE in FDC or fixed dose combination drug products. I will repeat. How to overcome challenges in achieving BE in fixed dose combination drug products.
Sorry, right now I will not able to answer, but I will answer later by the email. I will email to you. Okay.
Sure. Okay. Actually, Ms. Ariska have 2 questions, and the last is especially related to the role of the metabolites in determining BE or related to drug-drug interactions of each active substance that will be combined in fixed dose combination, both from pharmacokinetic and PD pharmacodynamic perspectives. It's about fixed dose combination.
It is also about the fixed dose combination. May I answer later?
Yes,
Okay.
sure, Professor. So can yes, send the email to you.
Okay.
Okay. Is there any question from participants again? Maybe if you have any question, or maybe I just want us. I mean, I'm not a pharmacy subject, not pharmacy department. But if bioequivalent is like in Indonesia, we know, I don't know, is it the same meaning or not? In Indonesia, like generic medicine is like cheap, and the patent is running out. And I don't know, is it bioequivalent related or not? Generic medicine, it's like we have a cheap drug and
sorry, I don't know the status of your country. It is included into the till now is recognized as the LDC country. Sorry, Indonesia is the LDC country or the median? Dr. Noor?
Mrs. Melania?
Can you hear me?
Can you make it clear? Because I'm not so.
I'm sorry, can you
familiar.
repeat, Prof. Mossadegh, what your question?
Bangladesh is the LDC country, so we are enjoying
what
the
the
facility.
explanation
but
of LDC country?
LDC means the low income country.
Low
The
income.
LDC country is enjoying the TRIPS facility till the 2033. I mentioned in my slides. The LDC country will enjoy the TRIPS facility. LDC country can produce the generic drugs without giving the without getting the permission from the inventor. So I don't know whether the Indonesia is the LDC included in the LDC country till now. Is it a LDC country, Indonesia?
I think Indonesia is not LDC country, I think.
Okay, they will because they are not the member of the LDC country, they will not enjoy the TRIPS facility. Okay, so they will not produce the generic drugs if the patent the period of the patent expired by expire. But Bangladesh, as a member of the LDC country, without permission from the inventor, can produce the any generic drugs. So for that reason, we are producing the 80% of the generic drugs and providing the providing a marketing in Bangladesh, also marketing in Bangladesh, and also exporting in Bangladesh in Bangladesh with a very low cost. Due to the TRIPS facility, after expiring the TRIPS facility, we will not able to produce the generic drugs and will not market in our local market, also export into the international market, will not able to produce such a cheap cost. Okay.
Understand. It's kind of depend on the low income or middle income or high income. Okay, thank you very much.
WTO has officially given permission the TRIPS facility, provided the TRIPS facility only for the LDC country, 49 LDC country. As a member of the LDC country, we are getting this privilege.
Okay, thank you very much. Is there any question? So some of the pharmacy expert has already joined.
Actually, sorry, I am not a pharmacist, so that some
pharmacology.
clinical, some lab-oriented work, lab-oriented questions that you are seeking answer from me, I will provide you with the consultation of the pharmacist.
Yes.
Okay.
Thank you very much.
I'm a clinical pharmacologist, so.
Clinical pharmacology. Yes. Okay. Is there any question for the last question? If you have. Okay, if not, so the time is up. So okay. Now is the end of the session. So I will give back to the moderator. And thank you very much for Professor Abu Syed Musaddiq. Maybe we hope we can collaborate again in the next agenda, maybe in the scientific paper or scientific conference among two university. Thank you very much.
Thanks everybody for inviting me. And I'd like to invite Noor and all other participants to visit the Bangladesh. Okay.
Thank you very much, Professor.
Thank you, Prof. Musaddiq.
Yes. Bye-bye, Professor.
Okay,
maybe,
bye.
Yes.
Sorry?
I will give back to the Master of Ceremony. Yuki.
Thank you, Mr. Andrea, for moderating sessions with the Honorable Speaker. Excellencies, participants, ladies and gentlemen, we are now arriving to the end of our agenda. Before that, we would like to remind you to fill the link of attendance that we will share in the chat box. Please fill the link now and we will take 1 minute. Excellencies, participants, ladies and gentlemen, on behalf of the Second International Lighthouse Student Conference 2022, we would like to thank you for your participation. And don't forget to join with us again for tomorrow's session on 8 a.m. Western Indonesia time. I am Yuki as Master Ceremony. I want to say thank you very much and see you tomorrow.
Thank you very much, Professor Abu Syed Musaddiq. Nggak apa-apa udah.